Dr. Nanjappa. I like Ajay Prasad sir to introduce Nanjappa sir.
Good morning. Hello. Yeah. Welcome all to Bilaspur. Nanjappa is my classmate and he needs no introduction because he is doing extensively RIRS and we are eager to hear from him the tips and tricks of RIRS. Please.
Good morning. First of all, let me thank the West Zone. Left kidney turn towards the left side. And this makes it easier when actually you're operating in the lower calyx and your hand movements become much easier. So this is one tip which is very, very important here. Which access sheet should I use? The access sheet is simple. You always, when you start your program, you have an access sheet. You want to use an access sheet. Now in this, one important thing is it depends on the size of the ureter and it depends on the size of the scope you have. So there are two things which we have to decide over here. So how will you decide the size of the ureter? Very simple. Do a visual calibration. Take in a 7.5 ureteroscope in. If it walks up to the PCS, you can put in a 10, 12 or a 9.5, 11.5 access sheet. So you can open that. So you know your ureter can accommodate that access sheet. Secondly, if it's a pre-stented, you may use an 8, 9.8, which if it walks in, takes a 11, 13 or a 12, 14. And if both don't go in, you have to then backload your scope. So this is on the ureter. Now you want to know even the size of the scope, because if you have the smallest access sheet, but your scope doesn't go in, Acha, you have something get switched on here. So then what is the tip? The simple tip is there is a formula for that, but don't go on this formula. 2 French bow, then the maximum diameter of your scope should be your access sheet. Things will be very, very simple here. So in an access sheet, if you apply jelly over there, And normally we apply jelly and we put the axis sheet in. And in a prolonged case, sometimes your axis sheet doesn't come out, it gets stuck. So the small tip here is put in a glide wire. I mean, you have a wire in along with the introducer and slowly start when you're retrieving the axis sheet with a continuous traction, or do a small rotational movement. This happens sometimes, that's why I put it over here. Now, when you're backloading your scope, normally what happens? See, this happens normally. When you're backloading, the scope gets stuck in the bladder. What will be the tip here? The tip is very simple. First of all, keep your bladder empty. That's very important. And secondly, rotate your scope by 180 degrees. When you rotate your scope by 180 degrees, the introduction into this ureter becomes very easy, into the ureteric orifice. Now the tip over here is hand movements. The very important tip is always think opposite. So here, when we are operating on the right kidney, how will your hand movement be? Your hand movement will go to the opposite side. That is, you move it to the opposite side and then do a deflection. So this is how your hand movements are done. Same thing on the other side. When you're operating on the left kidney, your hand movement goes to the right side. And this is the tip of how to go about. Now in the laser fiber, should I cleave my laser fiber? Should I cut my laser fiber? Yes, definitely. Because if you keep on using and your case prolongs quite a bit, every 15 minutes, try and see that you can cut the tip of the laser fiber, because this will deliver the best energy and you can have a very good fragmentation or dusting over there delivered at the tip. Should I strip my laser fiber? Definitely, you should not strip your laser fiber nowadays, because you see over here, definitely it is seen that if you strip, first of all, you cannot identify your laser fiber. That becomes difficult. Second important thing, what happens is in a deflected scope, when you introduce the laser fiber, you can easily introduce an unstripped laser fiber inside. So stripping is now gone. Now comes to the working channel position. This is when you start doing difficult cases in the lower calyx and you have to really go down. Then what happens is, if you have a scope, same thing here happens. If you have a scope with a 3 o'clock working channel or a 9 o'clock working channel. So for a scope with a 3 o'clock working channel would be best when you work in the right kidney of the patient, and a 9 o'clock working channel would be blessed in the left kidney of the patient, provided the calculi are placed posterior, in the posterior calyx, in the lower posterior calyx. So that becomes, see here, when I'm with a 3 o'clock working channel and working in the opposite kidney, see how things become easier if I take a working channel on the other side. So that means in difficult cases, you have to have a scope with a working channel either on the 3 o'clock or on the 9 o'clock. Is it necessary to have two types of scope? No, it's not necessary. The tip here is very simple. You take your scope and you just rotate your scope by 180 degrees when you're doing such difficult cases, which means that the deflecting arm lever now comes in the front and you're deflecting your scope with your index finger and your middle finger. So you do a upward deflection. So when you do this, you can easily turn your 3 o'clock working channel, working position, to a 9 o'clock working position. So this is how you can do that. You can completely rotate it and you can do it from the opposite side. Now, if your vision becomes blurred, what are you going to do? What is the tip over here? Very simple. Just take a little bit of contrast and put it in. It will clear off. So this is just the tip to tell you all. Now in the laser settings, I will just cover it to tell you what happens in a laser setting in either a holmium or a thulium, any machine you use. What are the tips for the laser settings? Very, very simple. The first thing what you have to set is your fiber size, because if you don't select your fiber size, because most of these machines don't have their RFID, the RFID is deactivated. So you may actually fire more energy than what can be taken through the fiber and damage the fiber. Forget damaging your fiber, you can even damage your scope. So the first thing, don't forget to set the fiber size. Second thing is setting your pulse width. That's the first thing which you're always supposed to do. Some machines may have a pulse width straight away showing as short or long, but most of the machines have the modes, and nowadays the newer generation of machines have preset things, so they don't allow you to set your pulse width, which are there in the thulium fiber laser. But in the holmium, the newer generations allow you to set your pulse width as much as you want, and the next thing important is setting your pulse width, after which you have to set your energy, and last but not the least, you have to set your frequency. So this is how, if you know how to set your laser settings in any machine, any, whether it is holmium, thulium, any machine. This is the thing to follow. And very, very important. So the tip over here in dusting, we always have a longer pulse width, less energy, and maybe the frequency according to the speed which you want to go. And the tip for fragmentation is always have a short pulse width. You can have a higher energy and again a frequency which is kept very, very low. In a popcorn or a pop dusting, depends, both can be on the medium side, but it depends whether you have a shorter pulse width or a longer pulse width. When you have a shorter pulse width, it is popcorning. When you have a longer pulse width, you do something called as a pop dusting, and that is what happens. The tip over here when you're dusting is don't touch the stone. You're not supposed to touch the stone, but just be away from the stone. Now, there's a very big debate on this going on. How much should be the distance you should keep? In holmium, the bubble is bigger, so you can be slightly away from the stone. But in thulium, you have to be very near to the stone because thulium has a very small bubble in front, and that's why that is the trick in doing the tip over here. The second is how do you know what size of the fragment is there inside? Because whenever you want to pick up a fragment, you should know its size. So it's very simple that you start and compare it with your laser fiber. The moment you start comparing, you know a 270 micron laser fiber is the core size, but the actual fiber size is around 400 micron, which is zero point 0.4 of a millimeter. So it will be that, and then you can compare it if there's a guide wire inside, that a 0.038 guide wire is approximately 1 mm, or the tip of your scope, which is around 2.8 mm, which can be seen on fluoroscopy. Sometimes this can happen. What is this? This is a stone being stuck with a basket. So what will you do in this situation? Very simple. Always use a smaller sized basket so that you can put a laser fiber just along it in the same channel and break the stone and take it out. So even in a stick basket, this is the trip. Always use a very, very thin basket. So basket size or any accessory used should be less than 2 French. And last but not the least, this is a broken laser fiber inside. So if you sometimes have a broken laser fiber, your laser fiber can break and fall into the pelvis. Now, what can you do in this situation? The tip here is very simple because you can't pick up this laser fiber as it is. It's very difficult to pick it up from any basket. So what you do, you just increase the bulk of that laser fiber with either a blood clot or a stone fragment, and you can pick it up. So these are the few tips which I wanted to discuss with you all for RIRS. Thank you. Thank you very much.
Thank you, Nanjappa. Very nicely and elaborately explained minor details of RIRS, including the procedure as well as how to handle the instruments. It is important because to have a good result, you have to know how to use the instrument as well as safety of the patient and the instruments, because instruments are very delicate. Uh, I have one thing to ask, like, do you recommend patients to be stented before procedure, and should we attempt in cases like horseshoe kidney or so?
See, the very good question, Ajay. Pre-stenting. Yeah, pre-stenting, do it in the start of your training program. When you're going to start your training program, try and see that you pre-stent all the patients, because here you will not have any disappointment. So if you're a newcomer, I would definitely recommend stent your patients. Of course, the choice of the stone is also important. Be less than a centimeter so that you can, go for this. But as you go on doing multiple cases, pre-stenting is not recommended. Pre-stenting is only recommended in a patient where if you're very worried about a patient being on anticoagulants, a solitary kidney, a pediatric patient, these are the patients. Or if you have an infective case and you want to postpone the case further by just de-obstructing that patient. In only these cases we pre-stent our patient. Otherwise, we never recommend pre-stenting nowadays. But if you want to start your procedure, start your program, definitely pre-stent. And secondly, never start doing horseshoe kidneys at the start of your training program. But there is no reason not to do a horseshoe kidney, because if it's indicated and you are trained well to do flexible, horseshoe kidney is one of the very good indications to go on and do your RIRS.
So I have just one question. You showed how to load flexi on a guide wire. So you recommend to do flexi without access seat?
Yeah, definitely. There are indications when you have to do it flexi. So maybe in the start of your program, you may not do it without an access sheet. You may always use an access sheet
Yeah.
because that keeps your, scope, protected. But nowadays, with the availability of those digital scopes, limited use, and all these things are now, these programs are going on. Straight away, if your ureter is not accommodative, really not accommodative, and still you feel that only a scope can go up, why don't you just backload it over a scope and put it up? So I think access sheet is today, I'm standing over here and discussing about access sheet. 1 year down the line, there will be no access sheets. There will be no access sheet. There will be nothing like an access sheet because things are changing rapidly. We are having suction coming in. I think in the next talk, there'll be a beautiful suction, which is equipment which is going to come in. So when suction is there and your whole process in semi-rigid ureteroscopy, are we ever using an access sheet? We are not using an access sheet. So flexible, we are using only for introduction. So if your flexible scope, Revo D is the new flexible scope which has come in, which has got a semi-rigid and a flexible tip. So Wolf has already launched it. And if you see that scope, you don't require an access sheet. You're going to do your whole flexible ureteroscopy like you're doing your semi-rigid
Yeah.
ureteroscopy. Instead of working on the upper ureter, you're working just in the pelvis. Bas, itna hi difference hai. So access sheet is going to be passe. So I think within a year or two, nobody is going to discuss on access sheets.
Thank you.
Any questions? Okay. Thank you,
Thank you.
Nanjappa.
Thank you.
The second presentation is by Dr. Hiren, and he's talking on RIRS setup and armamentarium. Dr. Hiren, please.
I'd like to add something that Dr. Hirin has done a fellowship in endourology from Amsterdam, and we have a fellow with endourology. Thanks. Please.
Good morning, everybody. And I would like to take this opportunity to thank the West Zone Urology Society and Council for this opportunity. It's an honor to have our urology president and West Zone president to conduct this meeting. After an excellent lecture, I'll just go on the armamentarium of RIRS. Many of us already urologists, we are doing ureteroscopy, so we are used to the setup. But there are some small changes that we should incorporate to do a flexible smoothly. So this is the basic OT setup. We have a video camera trolley, endourology instruments. It's important to have cystoscopes and ureteroscopes because Nanjappa sir just said that we need to calibrate the ureter before proceeding with flexible. We need to have an irrigation system so that the pressures in the kidney are controlled. C-arm and lasers, either a holmium or a thulium fiber. The setup, you can have it the way you like, but there are some small tips and tricks. If the irrigation is on the left side of the patient, then it does not cause any drag to your scope because most of the irrigating channels in the flexible ureteroscope are on the right side. And it's good to fix the irrigation system on the leg so that your assistant is not pulling you. So I'll demonstrate that when I'm doing the case today. And the C-arm and video camera trolley setup, you can have the way you like it. And laser should be in a nearby position so that there is no drag on the fiber and it does not break. This is a very famous slide from Dr. Olivier Traxier. And he says that you should organize the trolley in such a way that it should be below the leg of the patient so that you can keep your instruments easily. You need not have an assistant. Again, we'll demonstrate that. and he calls it the dry corner and the wet corner and working space. And you always need to have a bowl with saline so that you can irrigate your wires and access sheath and equipment. Sir already spoke about the position. So this is the position, and this is also again a slide by Professor Traxier, wherein you stand like an archer. We all know the parts of the scope, but it's important to know your instrument well and see how it rotates and what is the deflecting mechanism. So deflection up and down, there are European and American styles. And when somebody had asked this question in one of the meetings, Professor Traxler said why the European system is, why the deflection is in a particular way. So he said in Europe, when we are doing ureteroscopy, while going up the ureter, we are bending down, we are putting the instrument down. And that is why they have a deflection. When they press down, it goes up. So, and in the American system, you have that is logic, and whereas the European is anti-logic. So, up is up and down is down. It depends on what you're used to. I'm used to having a logic system. That means when I move my thumb up or deflect up, the scope moves up, and otherwise it moves down. So these are the movements which are very important. Again, we'll demonstrate them in the OT because the instrument in your hand is important. So they are macro and micro rotation. The macro rotation is when you're holding the handle of the scope and you're either moving it or deflecting it up and down. But your left hand is very important while moving the scope in and out, and also having more deflection when required. So that I'll demonstrate in the OT, and I think sir will also show that. The instrument characteristics, it's a 5.3 to 8.7 French distal tip. Active deflection in most of the scopes is up to 160 to 270 degrees. Secondary active deflection is 130 degrees. Secondary active deflection we get by pushing the scope against the wall, and then it bends down further. Working instruments are laser fiber and baskets, and we have digital and fiber optic scopes. These are the different types of scopes that are all available. And some of the newer scopes and the disposable scopes are also there. And we have this newer Bioride scope, which is disposable. Sir also spoke about working channel, but we must be aware that different makers have the working channel at different positions. Like Wolf has it at 2 o'clock position, the ACMI has it at 6 o'clock, Karl Storz has it in FlexX2 at 9 o'clock and FlexX-C at 3 o'clock, and Olympus has it at 9 o'clock position. Then we see the difference in the image between the fiber optic and the digital scopes. And the digital scopes have a dual LED light and a mini digital camera at the tip, and endoscope protective system. Now the accessories, which are very important before starting the program. You need a port seal every time so that you can fix the laser fiber. You need the right configuration of the basket. Like sir showed that if you are stuck in a situation and you are using a 2.2 French or a 3 French basket, you will not be able to put a laser fiber by the side of it. So 1.7 French or a 1.9 French basket is what we should have. Ideally a 200 or a 272 micron laser fiber and access sheath instrument. These are the things that we need. So just an overview of the accessories. You need wires, catheter, access sheath, port seal, irrigation system, biopsy and some basket, and sometimes a biopsy forceps. So wires, we can use any wire. Normally a glide wire would do, but in a difficult anatomy, you would require a hybrid wire, which has got a flexible soft tip and a nitinol core. So there are some hybrid wires like this sensor wire from Boston Scientific, and this is the literature supporting that. And then you have a bi wire from Cook. So it has both the ends which are soft. So if you want to backload the scope, you can use the wire. And then you also have a Roadrunner, which is also from Cook. So it has a soft tip but a hard nitinol core. These are the configuration and the sizes that are available for these wires. Then catheter, it is always good to have a dual lumen catheter, at least one standby catheter, because sometimes if you need to have an extra channel to put in a wire or something, or put contrast, then it will be very helpful. Access sheath, sir already said how do we select the access sheath. We should calibrate the ureter, and there are various access sheath available. But normally, when we have a non-pre-stented patient, then a 9.5 access sheath goes in if a 7.5 URS scope has gone in the ureter, and 10 or 12 is used for the digital scopes, and 12, 14 is the larger access sheet that we have. So this is Navigator by Boston Scientific. It's a good access sheet. Then you have Europass from Olympus. It has this tip that can be seen on C-arm. This is the flexor access sheet from Cook, which is 9.5 by 11.5 and various sizes. And you must also have the smaller sizes if you are doing challenging cases like a pelvic kidney or something. You need 28 centimeter access sheet, and normally 35 and 45 is available for female and male patients. So these are the flexor. There is another flexor parallel access sheet which can be used for placing an extra guide wire. This is a new access sheet from Cook. So instead of a dual lumen catheter, you can use this access sheet to place the guide wire. That is showing how to place this dual lumen, the new access sheet, how to place the guide wire. So it comes out from there, the guide wire. So there will be a guide wire outside the access sheet, which will be like a safety guide wire. Then this is a very important device, the port seal. Normally it is available with our basket, and some of the new digital scopes are also giving this port seal along with it, but you can buy it separately. And it is important because you need to fix your laser fiber while doing the procedure. Irrigation system, it is very important to maintain the pressure in the pelvic elastic system to avoid complications. So that's the normally 1 centimeter of water is 0.73 millimeter of mercury, which is equals to 97 bar. So that is the exact height. 40 centimeter is what we should have if you're doing gravity. But no, these irrigation systems have been tried and tested, and there are papers saying that they provide a good, important, the amount of pressure in the pelvic elastic system is not exceeded by using this. So it's a simple device like our TUR set, which can be attached to both saline bottles. It has a chamber which should be filled so that there is no air coming in, and then we have this pump. So this pump can be fixed on the patient's leg so that your assistant can help and just move his hand over there without pulling it. And because this tube is short, if you have a 100 centimeter extension, the irrigation system will not hang and pull the ureteroscope when you're doing the procedure. Now, suppose you don't have this irrigation system, or the patient cannot afford it because it costs 6 or 9,000 rupees. You can do this irrigation system by using a simple TUR set, attach a pathfinder, and attach an extension. We have also this single action pumping syringe by the Boston Scientific. So it fills on its own. It's like a syringe, you press it, and then with the spring action, it fills up again.
Dr. Hiren,
You also, sorry?
there is a message from OT that they are ready already.
Yes. This is a irrigation system which controls the temperature. Mostly we don't require it. It's more in the colder countries. And like I said, we can make our own irrigation system. The working channel is 3.6 French. Therefore, you need good irrigation when you are using accessories through the irrigation channel. Baskets, 1.7 French nitinol N-gauge basket is exactly what you should use so that the irrigation remains good. N-compass is another one which can be used for getting more gravel because its configuration is like that. And this is an N circle which is used to relocate stones from lower calyx to upper calyx. And then we also have a helical basket. So this slide, sir, already showed that if you have a larger accessory, your channel will be blocked. And this is a biopsy forceps that you should have for taking biopsy in case of upper urothelial cell carcinoma. Thank you.
Yeah. Thank you, Dr. Hiren. Very nicely understood that everything is important, starting from managing the trolley, the instruments, and all. There is slight change in the program. Since in OT we are ready for cases, so the two lectures will be later on. And I'll request Dr. Nanjappa and Dr. Hiren, please be to the dais. We will have a memento, small memento. Your And I invite Dr. Prashant, Dr. Shrikant, and Dr. Yogesh for the next session.
Good morning, everyone. Chandra Mohan sir, can you hear me? Sir, over to you, sir.
May I know who is speaking in the audience, please? The moderator. I am Dr.
Hello.
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 I'm coming there, Chandra Mohan.
To address who is there in the audience.
Yeah, I'm Dr. Prashant Bhagwat here, and Dr. Shrikant sir is there.
Dr. Shrikant Padwe.
Prashant.
Good morning, everyone. I first of all thank the Urology Society, the President, Secretary, Dr. Prashant.
We are not able to hear you, sir.
Hello.
Hello. Hello.
Hello.
Hello.
I thank Kamlesh for giving this opportunity in his hospital. Very good setup, 4 theaters. And in our theater, now Dr. Kanti sir is there, who is senior, and Dr. Prashant Murwandar sir, Dr. Sudhir sir, my colleague, and Dr. Ashwata. So they will also help me in understanding and doing the case study. But here, it is rented, right side store removed, left side store is present. It is a single store. If you see like this, everybody feels it is the easy case and we can do faster can be done. This is the impression from there. But once you see this IBP, every IBP is different, as Dr. Shabir was telling that, like every phase, every IBP is different. Without doing RGP, better not to say easy or difficult. It's mainly difficult because the system is 26 small. The store is, if I to see here, this is the store. You have to follow that to see where is the store. That means it is impacted. Only this shadow, light shadow background of the contrast line scientifically. Nowadays, we don't see this type of thing because we are using CT. This is the advantage. You are mentally prepared that there are different type of cancers, anterior, posterior are there. So you have to function whatever you want. So this is the store factor approximately 1.4 centimeters of this. So you should be careful and with PUJ whatever you are doing. These type of cases, PUJ should not be used. So ideally, middle calyx is better. For me also, middle calyx and store migration chances are less. These are fine. Without wasting time, we will go to the position. When you come to the position, a lot of people are interested in this because there is a fear of intestine injury because front of the abdomen we are seeing. We always know that. Front of the abdomen. The front of the abdomen is intestine. So whenever we puncture, we have a feeling that we will go to intestine. This is the first fear of the PCR. To avoid that, there is landmark required. In short PCR, there is no landmark required. You have to come floor, it is flat. Everybody knows that it is ridge. See, this is the position of the patient. See, simple. Please iliac crest, umbilicus, and we are first thing is that feel the rib. Then you understand that you are feel the rib. The tip of the rib is seen already. What you do normally, you puncture below the tip of the body. Without doing anything, you have some access. But nobody likes to see like this. Don't we say this artery. If you keep this hand like this artery force drops down. That is the fact. If you take only 1 minute, you put the ear press here in patient. Ear press here, in the ear press, and this is the post here. Just draw a line on your this thing. If you turn like this line will go anterior. Then you can go to the post. Our fear of having intestine here should go if you want to spread. If you go here, definitely intestine will come. If this ear press is below, then it will not. If you go below this boundary, it rarely comes. Won't come. The moment you turn, our lifting will fall away. So technically, it is less tough. This is first. Second position part is bring the chain up to the here tension will be there. Whichever side we are doing, you keep that side this low. Two aspects. Whether to turn first or economy first. We do economy first. See one position where you can access the ureter, one position where you can access here, one position you can access the upper and the laparoscopy can be done. That is not very difficult. The position we are doing now. Simply this will be straight. First is the edge of the table. Any pro-optimal patient, edge of the table. Then you keep this straight. And this little slowly sit up. Like this. Here it should come. This child is little small, table is big for her, so you should be careful. You can turn like this. More this leg is straight, more for this leg. More this leg is dichotomy, RAI. For example, you wanted to do RAI, keep like dichotomy. If you wanted to supply, I don't want to RAI, you can keep straight also because you have exposure of this stuff. So here I am doing ureteric catheterization in this position so that I will show how the ureteric artery goes little up to this position. When the dichotomy is not there, it looks one side off the ureteric artery is slightly greater than off. So that is what. See, because the chair is small and table is big, see like this one. This is the position. You can come in the cell. This is the position. Now to fix it, we can turn the patient simply where is the pad. Simple cover fold. This much is more than enough. Where we should keep coming. This hand will go that side. You can see the blade here. See, the shoulder blade is there. Don't keep here. Shoulder blade one small. And one more small here. Not even necessary. Small. Next part of the record already shifted. See, this part is exposed now. So one more small cover will keep. So one will put a नीचे रखें. Superficial position is going. That's all. Now see here. Here एक बार click करो. This position means 5 organs. This is the position I have. This is the position. It takes 1 minute time. See the position. Ipsilateral, little bit low. Contralateral, carbon economy. Now all the area is exposed. Siam, please fire. Fire करो. कोई कुछ नहीं. Siam, because Siam means Siam. See. Now see, previously the stone was here. Now you come little inside. Inside में मेरी तरफ थोड़ा. बस थोड़ा तो movement. Siam. See, this is the position. So this whatever in the RGP now we will see. We remove the stent, ureteric catheter. Now the landmarks once again are iliac crest, posterior axial line, rib अच्छा दिख रहा है, and the erector spinae muscle is also seen, and other rib also you mark. You don't require anything. Usually you imagine this quadrants is divided. This is the area where you puncture. This area. Supracostal, supracostal. If you want to go medially, I can go. Erector spinae से medial no कोई भी नहीं जाएगा. So this is the maximum medial I can go. I can easily go. And this is the middle calyx region. This is lower calyx. If you can divide this into 3 quadrants like this, usually these 2 से puncture हो जाता. These 4. In supracostal, these 2. Wherever you keep it like this and you do the puncture now.
No, same thing like prone. Only thing is that you are going up. If you go more posterior, it is superficial, like this. So start from like gradual ascent here. What other prone people say, gradual descent. Here you purposefully go towards the rectus spinae, slowly come back. Then how the intestine will come? If you go like this here, then come back, intestine can be punctured. Go posteriorly, then anteriorly, then anteriorly. Usually in supine it is horizontal, like this. That's why movement into the ureter, movement into the lower calyx is easy. For example, upper calyx. Lower calyx, you have to look down. Looking down is easy. Whereas in prone, you have to come from here and then look down like this, easy. So in supine PCNL, lower calyx to upper calyx is easy because upper calyx is down posterior superficial. That is all about the rest all. We can, no need to go theory. We will go for puncture. Now we can go for lecture there or any other case. So that I will put ureteric catheter, nothing great, same ureteric catheter. Once draping is done, we can come back and show the puncture. Thank you. Any doubts regarding the position? You can ask. Simple.
Yeah, that's very nice, and you showed it very elaborately.
Sir.
In the meanwhile, by the time you start,
Yes,
I will
sir.
ask Dr. Jackie Lalmalani to present with
Yes, sir. Thank you, sir.
his lip.
हाँ हाँ ठीक है, तो हो गया बस. थोड़ा ड्रेपिंग करो, पेंटिंग ड्रेपिंग.
Who's handling the laptop
एक
here?
फोरसेप्स चाहिए निकालने के लिए, स्टेंट. फोरसेप्स नहीं है, दिखने रहा.
I just want to thank
नहीं, oral
Bilaspur
नहीं, इसमें
Urology
forceps जाता है ना.
Society, Chhattisgarh Urology
oral.
Society for getting West Zone here. Thank you very much. And can I have my presentation? इसमें है? ये भी चल रहा है? So I go back to my presentation on semi-rigid. We are all advanced now. We are all talking about RIRS, but I'm going to my old topic. And obviously, all of us know that rigid URS is the cheapest mechanism of doing a surgery. Flexible is expensive. All of you know. Even we have been starting doing RIRS since last 4 years, and we have already changed 4 ureteroscopes.
अच्छा थोड़ा सर को हेल्प करो.
So the only advice I will give my friends is you must have a 4.5 French short URS. 4.5 French Wolf or Choly or whatever, it handles just like a cystoscope. And despite it being only 35 centimeter long, you can reach the renal pelvis on the left side in females. And in males, you can reach L3, L4. I've forgotten what is glide wire, what's zebra. We don't use wire at all. You walk in exactly like how you do a cystoscopy. And it can take a laser fiber 200 micron, 365 micron, and still have sufficient irrigation with gravity. So I think this 4.5, I was told by Dr. Hiren Soda, you must try it. Last 5 years I've been using. The vision is outstanding. It's a brilliant scope, and I think all of you must have a 4.5 French.
थोड़ा पेशेंट को नीचे ले लोगे, थोड़ा नीचे.
So we all know the advantages. I've been doing ureteroscopies on daycare since last 24 years. I don't admit a single patient. We usually do it in the morning, and by 3 o'clock, 4 o'clock, we discharge all the patients of ureteroscopy. Of course, I don't only do ureteroscopy, I also do ureterorhinoscopy, and I'll show you some of the plates. What is important is this slide. You must understand that there are a lot of tortuosities in the ureter, and there is a blood supply which is supplying the ureter, and you cannot be really rough moving the ureter too much right, left, because what will happen is it will damage the blood vessels also, cause some degree of strictures. And what you have to realize is once you cross L3, suddenly the kidney becomes posterior, and there is a marked angulation, so that a rigid to go into the upper third or to a rigid to go into the kidney is extremely difficult. But what we tried, and this is about 14, 15 years back, I went to the CT scan room and we pushed the kidney with our hand. So what we do is when we are approaching upper third or renal stones, then we have a towel which is kept behind at the posterior level. Then my wife is the anesthetist. She's a doctor. She knows what is important, which is why you need an aware anesthetist. she can pick up the kidney and bring it in line with the ureteroscope. You can see so nicely that now the kidney is above just by putting the hand. That's my hand there. Is there a pointer somewhere here? Yeah. So this is my hand here. And if you see, you can have the kidney come in front and the whole ureter in line. So this is the basic concept you must have in mind, that if you are doing a ureteroscopy for upper third or renal stones, this is what you need to do. You will have a towel back there. You will have someone pushing the kidney up, and you can treat it with rigid. So I'm just going through very quickly some of the stones which we have done. This is a large stone in the upper third with obstruction. So I've done rigid ureteroscopy, could not manage to clear the stone completely, and then we did a second URS. Now this is a large stone just at the PUJ. Patient had CA lung, and we could put a rigid very nicely. And this was the end result. These are the fragments, and you could see the nice Steinstrasse. Now, whenever we started doing upper third, many of our ureteroscopes would bend. And I thought I've lost my ureteroscope, that I should dump the ureteroscope. But the fact is, this bent ureteroscope makes it easy for me to enter the kidney, especially upper pole, middle pole, and some of it even inferior pole. So instead of this being a liability, this became an asset to me. So if you have this bent tip, you can easily go in. If you're somebody who has undergone ureteroscopy, I call it a friendly ureter. Of course, I want an aware assistant. And if there's a distal ureteric stone, it makes things even more easy because the proximal ureter is dilated. Now, this is a large intrarenal stone. And what we have done is we have put a rigid. And you can see the rigid is all the way inside the intrarenal pelvis. And we have been able to break it very nicely. Now, always, when you do lithotripsy, you depend so much on the surface area of the stone. Now, once you have broken this stone into this multiple pieces, if you give one sitting of lithotripsy, it breaks much, much better. So this is my hypothesis. Yeah, maybe I can open this. Anyway, I don't need this. So my hypothesis is the moment you break the stone with rigid into multiple large pieces, you have a double, triple, 4 times surface area, and the lithotripsy becomes much easier. And I can just show you some of my patients further which we have done. This is the same patient which we did. We gave one sitting of ESWL. I normally do all my ureteroscopes on the lithotripsy table itself. And you can see it required a second sitting, and we could remove the stent after that. This is another big stone here. Patient had a left non-functioning kidney and a right hydronephrosis. Cranium was 4. We could put a rigid ureteroscope and then do a lithotripsy. And then as you grow with more and more cases, these are the types of stones we have done. You can see a large stone, and that's a result after rigid ureteroscopy and one sitting of ESWL. These are the fragments, and those are the fragments. And then if you see this large stone again, this would be classical PCNL or even flexible. This would be too big, but we had the rigid in, and this is post rigid ureteroscopy. It's not RIRS with ESWL one sitting. And some of these patients have such a big stone load that the fragments would get impacted even with a single DJ stent. So I was reading through some articles, and the articles of saying put 2 DJs, you are doing big stone load. And if you realize I had 4 or 5 patients with colic despite a DJ. So we have put 2 stents here. So this is a large stone. It's at the renal pelvis. We have put the rigid ureteroscope. We have done the ESWL, and that's the result at the end of URS with ESWL. Now, this is another very, very large stone here. Again, it's not a very much dilated system. PCNL, of course, you could dilate very easily and enter. But we have put 2 stents. This is after one rigid ureteroscopy with one sitting of ESWL. So you can have difficulties in ureteroscopy. With 4.5, I've literally never had to balloon dilate the intramural part. You first enter with a 4.5 and then go into a 6.4 Olympus, or you go into a 7 French ureteroscope. If you have a lot of edema, actually laser should not be used when there's a lot of edema. I personally feel, I was chairing one session where Jaydeep Date talked of 6 strictures in upper third resulting in nephrectomy after laser ureteroscopy. And if there is edema, I always shift back to my old pneumatic lithotripta. So that's safe. It's not going to cause heat. It's not going to cause stricture. Once you deal with the edema, then you can progress further towards the stone. That's what I feel. Many times the edema you can reduce using just Conray. Conray is hygroscopic. You inject Conray and the edema will just subside. You will be able to see the tip of the stone. You can have migration of the stone with pneumatic, put a basket, then go back by the side of the basket and break the stone. And if you think the stone is too big, you can always come back a second time. Many times we see the calculus stuck to the ureteric mucosa. I use the lithoclast probe or the laser probe just to tease it off, and then I put a DJ for a longer period of time. Sometimes you hit a tortuous ureter. Then I do it on a lithotripsy table. I can't give head low, so I put a pillow below the hips. Then I use a trirumo glide wire under vision. I flush with saline to try and push back the obstructing stone. And some of the examples I just put here quickly. You have a ureteroscope like you have put a retrograde. This is how it's almost like a W. But if you go with the ureteroscope up to here, you can put the glide wire and then you can follow it up and you can reach the stone with the rigid itself. Of course, with a flex, it's not an issue. Or you have a like a T-shaped obstruction like this. You reach with the ureteroscope, then manipulate with one wire or two wires, and then you will be able to enter inside. These are some leftover DJ which we have dealt with a rigid ureteroscope. We have done about 7 or 8. Even it's not difficult to enter with rigid up to this portion, break the stone and take out the stent. These are some stones. You can see it's a large PU junction stone and an infundibular stone here, which we have done. Now this, of course, is crazy. A patient had a small ureteric stone. It was a dilated system. The entire stagon was within the renal pelvis with minimal extensions. So we have done this with a rigid ureteroscope. And that's the result. That's the IVP with a small stone here. And that's the result after a rigid ureteroscope. Now, I got into trap only in this stone, and I must show you this to tell you how bad, how disastrous a Steinstrasse can be. This patient's brother had undergone PCNL and patient had died. He said, I will not undergo PCNL. Simple as that. So I said, yeah, I've done so many. Let me see. And I made the cardinal mistake. This is the IVP of the patient. There's some edema at the just at the PUJ. And I made a cardinal mistake of doing stenting with lithotripsy. I should have put a rigid first and then lithotripsy. And this is post DJ and ESWL. Then we did URS and ESWL. And you can see the Steinstrasse. Then this is a ghastly Steinstrasse like this. Crazy it was, absolutely. I heard yesterday when we were having dinner that somebody has done 100 lithotripsy sessions and 50 lithotripsy sessions. I did 5 in this patient. I got a heart attack. I said, what the hell am I doing? You can see the amount of fragments here. You can see this Steinstrasse. I could not even remove the DJ. So to remove the DJ, 1.5 hours, I went inside the ureter, kept breaking the stone. And then only I could remove the DJ. This is after 5 sessions in. This is at the end after I successfully removed the DJ, all the fragments passed out. And one tiny stone was left here, which required a 5th ESWL. This is crazy. I felt this was crazy. This treatment took 3 months to take place, but there's no way I could convince him. And to be honest with you, just 2 years back, this is about 10 years ago, 2 years back, he came with 11 stones in the ureter and 4 in the kidney, all small. We put a rigid, broke the 11, 4, 5 went to the kidney. We used the RRS and we cleared him. Again, no PCNL he wanted. Now, as I said, what do you do with this 4.5 beautiful ureteroscope? I have so many pediatric stones now. I put this 4.5 short ureteroscope. I rule out an obstruction or posterior urethral valve. I use laser and I break it into dust. I don't put a catheter. I don't put anything. We do the patient at 9 o'clock. By 2 o'clock, 3 o'clock, he passes urine and we send him home. So today, if I have a child with a bladder stone, I would use the ureteroscope, break it with laser into fine gold dust, as many of us call it, and we would leave it alone. This is my last slide. This is a cystogram. This is a large bladder stone actually. Even there was no space for PCCL. Even when I did open, I had to deliver the stone with great difficulty. I got a forceps, gynec forceps, delivery forceps to lock the stone and take it out after a supravic systolectomy. This was a 980 gram giant vesicle stone. So thank you for sharing few of my cases. I thank you for your attention. Thank you.
Thank you so much, Jackie. Jackie, please come out to the stage.
Any questions, anyone?
My question to you, sir.
With this rigid ureteroscope, we have done about 140, 150 large renal stones. Although we are flexible now, sometimes when I see a still stone in the PUG, I still get tempted to put a bent tip and I do it, and it works brilliantly, absolutely.
Is willing, and you are also well versed with all the different techniques. So in all these patients today, which technique you will prefer?
I'll tell you, upper third and renal pelvis, I'll still go with the rigid. Let me be very honest with you. And that's what I do every day. And with this 4.5, the entry becomes so easy. I can tell you that we have done in an 11-month-old child. I've used a 4.5 for a 12 mm stone lower third and 12 mm stone upper calyx with rigid. But I did that in a pediatric hospital, which we have in Bombay called SRCC. But I would still go for rigid many of the times. Because after 4 years, I'm still not very good at RRS. Let me be very honest with you.
यूजुअली इसका नीचे इधर परफेक्ट आएगा सर. कैलिक्स पंक्चर होगा, मतलब if it is middle calyx, इसमें भी देखो
Everything is ready in the OT.
Right.
Hello.
टेबल थोड़ा हाइट कर सकते हैं.
Chandramohan sir, we are
Yes, sir.
ready
Right.
to see you.
Right. First step is injecting the contrast, off diluted contrast. There is a ureteric catheter. See, before you do any procedure, first thing everybody likes is see the stone on the C-arm. Then can you show the screen? And then put like this. Here also you have to show. Put the needle like this and confirm. Like same like prone PCNL. कहाँ गए आप? क्यों वापस चले गए आप? Why you have gone back? Come inside. Bas, stay there. See, now first thing is we keep the position on external like this and see
Dr.
where,
Chandramohan,
where we are related.
Can we have a picture-in-picture PIP of the C-arm as well?
ये दोनों एक ही बार दिखा सकते हैं.
Yeah, that's better.
Yeah, now it's okay.
That's better.
So like this we like to show first before injecting contrast. And never inject contrast. The surgeon only has to see while injecting contrast. Always keep ureteric catheter above the stone and then withdraw. Below the stone, if you keep, sometimes contrast may not take up in upper calyx. Now slowly by injecting contrast, we will withdraw the ureteric catheter if possible. Half diluted contrast, small child, narrow infundibulum, extravasation causes problem. So I am slightly skeptical, half diluted, inject contrast. While injecting, please see what is happening, which calyx is filling. Basic. See, now it's upper calyx. Now the stone is, continuously see the stone where it is. It is somewhere not in the pelvic region. See, we were continuously seeing. That is the trick in this case. So, the posterior calyx or anterior calyx, we don't know. That calyx we have to go. Now, everybody is seeing C-arm and this calyx, this was the reason where it is. You agree? Everybody agree? That is the importance of injecting the contrast with surgeon in the theater. If somebody comes, by chance, if you select this calyx and if you cannot reach into the stone, it is total waste. Now, this is really confusing why the stone is there in that calyx. It may be an impacted stone in the calyx or mobile stone, two aspects. This is a very ideal case for RIRS. That's why if I fail by chance, I don't have fear in my operation theater. This is why I learned ECIRS. If I have the stone puncture 1 time, 2 time, I will try. If it is not going, then I will go from below and finish it with thulium fiber laser and early, even a child. Only problem for the RIRS is ureter dilatation. Only problem for PCNL is puncture. Both if not happen, then you have to wind up, put stent and come out. Because this case is stented, honestly, if I have RIRS by the side, my stress will be 0. Ultimate aim is to remove the stone. So let us start puncturing this thing. So now I wanted to keep like this. I may not go exactly cup of the kidney. It is difficult to go to the cup of the kidney because you will go to the thoracic region. Already where I am above the 11th rib. But that is not correct because in supine PCNL you look up. That is the next difficult part. The entire needle looks up and long length. Itna length body ke andar nahi jayega. It won't go. So ultimately I will select a spot just above the 12th rib here in this region, in that angle. So I will select here. I will move the kidney and see. Blade. Like any other prone puncture I will do. Inject contrast. See here I am making a nick. I am making a nick. In children you should not make the nick deep because it may injure anything. Now I am reasonably posterior. See, this is posterior axial line. Even in prone you might have. See, this is horizontal. It's not like this. You can keep like this to go posterior. You can keep like this middle. You can keep like that anterior. This you should not do. Bending full legs you should not do. Now left hand I am stabilizing. Within just rib, see, you observe. I am going down. See, one calyx is dipping there. One calyx is dipping. That I don't want. So other calyx I wanted to aim. This. See, that is also moving. That means I am nearer to kidney. This I am there. Now I don't know whether I am in the system or not, but I am in the periphery of the calyx. I don't damage the renal artery with this. I may not get the urine. Don't worry. 30 degree up you shift slowly. Up 30 degree like this. Bhaiya. Sun nahi raha yaar. 30 degree up. Aisa. Slowly. Rotate. See what happens to my needle. You have to see. Right. Up. See. Slowly you move up. If the needle goes up, what does it mean? 30 degree up. ठीक है हाँ अंदर चले जाओ इधर अंदर see slowly it is in the same position. Inject contrast or saline please. Slowly in the same position. Under see, these are the common problems in live surgery. See, go up little bit. Go entire thing up jana hai. No, not this. Entire unit has to go up. No, not like that. You should not do like. See, this is the position I wanted to adjust. It is now inject saline. It is this position. Everybody is appreciating. Nobody is speaking from that side. If you don't speak from the audience side, I will be confused whether I am communicating or not. Please. Sir, is the Siam picture is coming, sir?
Yeah.
So 30 degrees also it is there. 0 degree is also there. Now turn 0 degree. Done. 0 degree like this slowly. Yes. Again 0 degree. So this is the periphery of the calyx. Now I will remove the needle and I will see whether the saline will come. No injection, saline or contrast inject. Saline or contrast inject. Saline inject. See, don't worry about this. You just wait and you don't inject contrast from the. Give me the guide wire. Guide wire. First step is inject the guide wire. Put the guide wire. If you put the guide wire, nothing will happen. Nothing will happen. This is the ABCD. See, I will pass the guide wire. मैं शूट करता हूँ. I will pass the guide wire. See, it has gone inside the system. Yes.
Yes.
Yes, it has gone inside the system. So, was I expecting any? If you want, see, it has gone inside the system or not? See, I will pass more.
Yeah.
It is slippery, but I will pass. See, I am into the periphery. If you have doubt, remove once again. This is a daring step. Remove once again. Now slowly saline may come. Inject saline and again pass the guide wire. If it takes the same turn like this, see, stone is impacted there. See, is it going or no?
Agreed.
Yeah.
Not sure. Sabir is saying not sure. What? Not happy. Then this is impacted stone. Needle give. This is impacted stone. Water will not come so easily. I will try to, because here the important advantage for me is I will hit the stone and see there. See,
The other calyx is also moving.
yes, sir.
What is the significance of that?
Transcalycial puncture. If you are not see here in this position, I am able to feel the stone. Matter over. So this is more posterior. Immediately the Harshavardhan told it is posterior. Now you see, I will remove it and immediately water is coming now. See, this is a fine adjustment. Clearly water is coming. Can you see?
Yeah. Now the guide wire will go.
Yeah,
Looks
now
like.
the guide wire will go. That
Yeah.
means if you are not very comfortable, don't see the guide wire.
Yeah.
It is 100% into the system. I don't have any doubt.
Right?
Yes.
Now,
yes.
because lower calyx it has gone, pelvis it has gone, it has gone into upper calyx. अब क्या doubt है? कोई doubt नहीं. Only problem is posterior middle calyx impacted stone. It is not the pelvic stone. It is very easy case for RIRS. Now surgery is not that difficult. Only thing is dilatation. Too much guide wire I kept inside because in children it will come out. Now next is blade cutting. So 30 degree, 0 degree readjust.
So there is a question, sir.
Yes, sir.
Sir, when there is doubt, can we put contrast after the urine
No,
has come?
no,
After
no.
the urine has came from the
No,
needle, sir.
no. I strongly see every person has different things. Sir. Why to put contrast? You tell me. Why? Give me the dilator. Small dilator. Oh, sir.
It will
Sir.
tell
Then
exact
sir, he is
position.
asking once
It
you
will-
are sure when the urine has started coming, if there is a drip, he wants to know whether you can put a dye.
Sir, क्या बोल रहे?
Now, when the urine is coming from the needle, sir,
Sir,
can we
I
put?
am asking why to put what you wanted to confirm. When the guide wire has gone into the pelvis, upper calyx here and there, what is the use?
The site of the puncture from where
Site
we
of
have
the puncture
actually.
is periphery. Our needle has never gone beyond the stone. Entire calyx is occupied with stone. See, I am dilating. Important part here in dilatation is entire kidney moves. See, this dilator has gone up to the stone. I don't want to dilate more than this. See, can you see the Siam, sir?
Yes,
Yeah.
yes.
I don't want to dilate. That is another important part.
And Yogen, he is able to feel the stone, no?
I can feel the stone. This is the advantage in this case. So now, only thing is that guide wire comes out. Terumo, ये निकाल दीजिए sir. Too much length guide wire is there. ये छोड़. Now give me the next dilator. So too much dilatation because the infundibulum is narrow. Go only up to stone. Otherwise, tear can happen if the calyx is filled with the stone. And you cannot dilate up to pelvis also this because it's
Yeah.
an impacted stone. And stone is not, see, I am going, posteriorly I am going, direction, see. Can you see the stone moving there?
Yes, yes.
Yeah. So there only you do 2-3 times, rectus sheath ko 2-3 times like this you do so that your next dilatation, see 1, 2, 3 I am doing. I am making a hole in the rectus sheath. That is very important in children. Otherwise forcible going further is disastrous. Next.
What guide wire and what kind of dilatation?
I am
Dilators are
using the
used?
normal Teflon dilators.
Okay. And the guide wire is a Terimo?
0.035.
Sir, 0.035 Terumo guide wire over which sequential Teflon. In children, I feel this dilatation you better spend time than directly going to single step because in supine, see now stone is seen washed out. Can somebody put see slowly I am rotating, see yeah. Now nicely stone is seen. So now I will insert the starch dilator. See, exactly I am there. I am not crossing.
I think the camera has to be adjusted. Your head is coming on the way, sir.
Camera, guide wire. Give me the starch big dilator. Now I will directly go with the starch single step dilator. These 3 steps will cause only 5 minutes, but unnecessarily tearing of the parenchyma will not be there, especially impacted stone. Very important point here for juniors is never inject RGP without surgeon in the OT. If somebody else injected RGP in this case, it might have been not good. So, okay. Now, this is a large dilator. You have to be careful. Guide wire aata hai. See, now it has gone into the ureter. That is also good. Everybody will be happy to go into the ureter. So, now this dilatation, Arshavardhan was telling yesterday, sir, don't push. See how much, see, itna dilatation karne ke baad bhi, the rectus sheath and skin is holding very tightly. This should be done very, very meticulously. No hurry at all. See, I am getting lot of resistance. I am withdrawing and doing again. So that this is what he was telling. Under dilate is better than?
Yes.
See, like that.
Yes,
Again
now you have-
withdraw. No injection of contrast here. No need. See, the stone is moving
the
nicely.
stone is moving.
That's next, the upper dilator. So this few minutes of time, not crossing suddenly the stone, will not cause bleeding. So you should never be in a hurry, whatever may be the case, especially in children, because kidney will be smaller and bleeding is not tolerated. Now over this dilatation is also difficult.
How old is this child?
See here?
Around 13, if I am not wrong. How old is the child?
But the volume of the child is, see here, volume, purposefully I kept, see.
The reasons from the small child.
बकल ले इसका ऊपर जा रहा मैं see
Sir, how old is this child?
but size के हिसाब से 7 year जैसा दिखता है. See sir, now lot of contrast should be injected. Sorry, saline. Now saline.
The voice?
See, can you see sir?
Maybe we wanted to know the age of the child.
Sir, 11 to 13 years.
13 years.
13 years.
Now
Okay.
inject contrast. Hold the guide wires. See, Prashant Mulwakar sir is holding guide wire very nicely. Having a senior urologist is advantage. See, पानी clearly आ रहा है. पानी clearly आ रहा है. So no problem now. The only thing is that in under dilatation, don't overconfidently remove the guide wire because entire thing doing again is difficult. Towel clip. Give me the scope. Bucket रखना. Bucket चाहिए. Now water please. No plastic sir. Now laser fiber ready. Now once एक टवल दे दो. गिव मी. ये सब हॉस्पिटल में तो लाइव वर्कशॉप में थोड़ा होता है, उनको फर्स्ट केस है उसको भी आइडिया आ जाए. वाइट बैलेंस प्लीज. सो वाटर प्लीज. वाटर प्लीज. सी नाउ इन सुपाइन PCNL फर्स्ट थिंग इज सक्शन है, सक्शन ट्यूब.
Can we have the end of view, please?
I am able to see the stone.
Sir,
We are not able to see the end of view.
I am able to see the stone end on. 1 millimeter also I have not extra dilated. End of vision please.
Chandramohan, we are not able to see the end of view.
End of view please. Focus करता हूँ. अब now end of view. This is the focus. Very excellent. End of view please.
Till we not.
End of view. Hard stone laser.
cameraman has to focus on the TV monitor.
TV monitor focus करो.
Yes, now we can see.
Can you see the stone?
Yeah, that's
Yes,
better.
yes.
So all around mucosa should be seen. This clot will be seen. Can you see the mucosa?
Yeah.
Can you see the mucosa?
Yes,
Yes,
yes.
yes.
So some amount of clot for few minutes will be there. See, can you see the mucosa?
Yes, very
So
clearly.
now start breaking with the, now everybody wants to know about the thulium fiber laser.
True.
See, thulium fiber laser is produced by 2 companies. One is IPG, another is from the Quanta. Now I am demonstrating the IPG, which I am using for 3 years. In this various settings will be there. I will show dusting, I will show breaking. We are using now in IPG, what is the advantage is energy levels are very low, very, very low, 0.1. And it can be used for enucleation. It can be used for en bloc resection. It can be used for the stone. Can you see the laser fiber?
Yes, yes.
Yes.
Laser fiber.
What is the setting of the laser?
हाँ सर, I will tell. एक बार machine दिखा देंगे सर.
Yeah, sure.
एक बार machine दिखा दे. Meanwhile, one should be careful that my ampla sheath should not come out because I have ampla sheath पकड़ लेना सर. No active bleeding, only clot which is there, so no problem.
No, we are not able to see the.
Can you see
yeah, please focus.
Can you see the?
Mm,
Can you see the this
No.
thing, sir?
No,
ये
no, we are
pictures
able
ले
to
लिया
see the
तुमने?
end of view only.
Pictures ले लिया तुमने? हाँ ले लो, वो pictures ले लो मेरे लिए, दोनों pictures ले लो. मैं तुमको बोला है वही ऐसा नहीं, perpendicular लेना है, मेरे पास इधर से आके लेना है. Sir ready? ये आ गया IPG का sir?
Yeah, I
Now
have.
we can see.
Stone and soft tissue, sir ये थोड़ा.
Yeah. And what is the setting like?
Second, sir, एक second. Water please. One second, sir. Water please here. Right. So this is stone and soft tissue is there. First you select the stone. Stone के बाद there is 150 micron fiber, 200 micron fiber, 360, 600. We are using 600 now. 600 करो. 600 12 French nephroscope में आराम से जाता है. Okay.
Okay.
And who is doing Harshavardhan? Yeah, Harshavardhan is also using this machine. He has told that if you use 600 with bladder stone mode, now we have kidney. You want to keep in bladder mode? Kidney mode first we will show. What is there? Dusting. This is popcorning. Dusting is 0.5 joules and 50 Hz, which is minimum. 0.5 into 50. And this, don't remember this, by doing only it will come. Too many combinations are there. Lot of people are complaining. It is not a problem. After 5-6 times in a theater you write down, it will come. I use the fragmentation mode, you go here. Yeah. Come, somebody come. Fragmentation mode आ गया. Whenever
Yes.
there is dusting and fragmentation, right side is dusting. That you have to remember.
Okay.
Whenever fragmentation and popcorn is there, right side is fragmentation. So in the order, right side become dusting always. Then fragmentation, right pedal. You can change the pedal also, he is saying. We kept like that. Now this right side means right pedal. Yeah. Okay. Now it is kept 1.5 joules and 16 Hz for fragmenting. We will see what happens. We will change the settings also, see what happens. Now, sir, good morning, sir. Sabni, sir. Sir. Sabni, sir has come, sir, here. Sir, actually, in this case, we thought pelvic stone was there. Suddenly, it was in the upper middle calyx. So, before injecting RGP, if you have, somebody else has injected RGP, we might have punctured some other calyx, might have not reached this. X-ray, take लीजिए, sir, for just for your comment. It was looking like pelvic stone, but it is posterior medial calyx, middle calyx posterior. So we did supine, we have dilated and stone is seen. Now I am using fragmentation mode with 600 micron fiber, chodo sir, on kidney mode. Yeah, now ready? Pneumatic lithotripter, sir, amplage. Pneumatic lithotripter, this may go into pelvis also. मेरे को laser fiber दे दो. So, pneumatic lithotripter problem in a narrow infundibulum and small pelvis is you can perforate. See, this mission takes 10 seconds. See what's happening in supine PCNL. If you do posterior puncture, it is very difficult to do. Anterior puncture is easy. So, I am moving the ampla sheath a little bit so that I will go upper part of the stone. Water, please. Like this. Can you see, sir?
Yes.
So everybody knows this, that we like the stone to be down, not up. So I am making the stone down a little bit by gentle rotation on either side. It's tight actually, so you should not force. ऐसा रखिए सर. ऐसा forcibly ऐसा अंदर रखिए. And laser fiber seeing is must. Light or left?
No, just to demonstrate to the people. इसको भी निकाल दो.
Can you see, sir? Now it ultimately dusts only.
Yes.
Yes, yes.
It doesn't fragment if you are a large stone, whatever settings you
Yeah,
keep.
25. We'll cut
First
this.
part
Give
it
me,
does only. If
scissor,
you have
please.
patience, please dust entire stone for 15 minutes and come out. Somebody flushing from below is good so that the powder will come out. In between you stop. Don't try to continuously, because see what's happening, some amount of storming effect will come with
18
any
French.
high wattage
Just
laser.
to demonstrate to
So
the
if you
people.
want to stop,
So
see the nicely where you are,
that's
and then
you
start.
remove all this.
It will never
So what
it
is
will
this
never
size?
fragment, even though it is in fragmentation mode. So now
Chalo, ye
Harshavardhan and Sabnis sir both
Okay.
are here.
Ye rakho.
If anything mode
Ye
that
rakho.
can do fragmentation of this,
Keep this.
I am not able to see any fragment. I don't want actually also. I want this type of nice digging, because stone is 1 centimeter. Like in RARS, it will take around 15 minutes nicely without any fear of leaving one fragment also. See how fast it is doing. See.
In the second OT, what are they going to take?
This is a hard stone. Wherever you make the powder, volume is decreased. So whether it is in the periphery, whether in the center, be comfortable in the beginning. After some time, water wash off will come and you will be comfortable. Don't touch the infundibulum. Middle calyx infundibulum is dangerous here. So its stone is impacted here. It will not go anywhere. Good for laser lithotripsy. Harshavardhan. Sir, Sabni sir, can we make pieces, sir, by any 1 and 10? Fragmentation mode, sir. Fragmentation mode, sir. Fragmentation mode 110 रखना. या उससे ज़्यादा ही है.
Going on very nicely.
Sir, are you getting the endovision,
Yeah,
sir?
yeah, yeah. We
Yes,
are
sir.
getting
Yes.
endoview, and it's
Nicely,
going
I
on
am digging.
very nicely.
Yeah, very nicely
Wherever
demonstrated.
safe, I am using this.
Sir Chandra Mohan, sir, one question.
Yes, sir.
Sir, everybody is not having thulium laser. Many of us are having.
You can use pneumatic lithotripter here.
Sir, no, we are having holmium laser.
Holmium
What-
is very good.
Sir, what is the setting you
110,
prefer in PCNL?
110.
110.
In a 30 watts laser.
Yes, sir.
See, now stone is broken. One stone is broken, there is a risk that it can go into pelvis. It's a complicated system. So continuous saline from below is must, but in supine PCNL, there will be some tendency to get the stone out only. Prone also.
Yes.
Chandra Mohan, the OT2 is ready, so
sir.
we'll switch over to the OT number 2.
Okay. Okay.
Can I
please.
get connected to the OT number 2?
But very good demonstration.
Sir, thank you, sir.
We'll come back to you again after
Yeah.
you complete.
Flush. Keep on fragments, na?
OT2 then.
पीसेस नहीं करना चाहता हूँ हर्षवर्धन. 1 मिनट छोड़े, बिकॉज पीसेस हो गए तो आगे पेल्विस कॉम्प्लिकेटेड है.
OT2.
Zebra guide
Hello.
कहाँ है, sister?
Am I connected to OT2? Yes.
Yes.
Sanjay sir. Dr. Khadgi.
Hello.
Yeah. Good morning. I'm Prashant Bhagwat.
Am I audible?
Yes, sir.
Yes, very much. You are seen and audible.
Hello.
Hello.
Yeah. Are you able to hear us, sir?
Yes.
Yeah. Can
So-
somebody brief us about the next case, please?
So am I audible to you?
Yes.
Yeah,
yes.
very
Okay.
clearly.
Very good morning to everyone. First of all, I would like to thank West Zone Urology Society and Chhattisgarh Urology Society, and special thanks to Dr. Kamlesh for giving me this opportunity to present, to demonstrate mini PCNL technique. So, my main work in Nepal is mini PCNL in 99% of the cases, and today I'm going to demonstrate you how we perform mini PCNL. So my regular practice, we perform mini PCNL under spinal anesthesia, and most of the time, about 70 to 80% of the cases, we go through the middle calyx and 10% through the lower calyx and around 10 to 20% through the upper calyx.
Can we have some little bit of history and X-ray?
Okay.
What you are going to do? Just a X-ray
Yeah.
picture and
A brief history, please.
brief history.
Okay. Kamlesh, can you give some history? Okay. 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 So it's a 23 years female patient with the left renal stone. Actually, she came with the pain on the left flank for last 3 months. So, are you able to see the CM IVU?
No, it is not very clearly seen. Yeah, it needs a bit more focus.
Okay. Can you just ask him to focus
Yeah.
on the
Please
extra-plane
zoom on to the
KUB?
yeah KUB, please.
That's the IVU.
That's IVP.
Yeah.
Yeah, that's a
KUB.
better.
That can
Can
be
you
seen.
focus it on? Can you zoom in, please? Yeah.
Yes, okay, okay.
Yeah,
seen
it's the
well.
left renal stone, left pelvic stone, it seems. Yeah. And a properly functioning kidney. Yes.
Okay. So today I will demonstrate you the instruments and my technique, the way I do mini PCNL. And I want to make this procedure as simple as possible. If you see, this is all about the instrument. These are my dilators. Mostly, I use a 10 or 12 French initial dilatation. Then most of the time, I prefer to use up to 18 French. If I have a bigger stone, more than 20 millimeter, then I go with the 20 French. Actually, this is a straw from McDonald's, which is very cheap, and I do use in my regular practice. This is all about the dilators and two-piece needle. I prefer to use mini nephroscope of 12 French, whose working channel is 6.5 FR, in which I can use up to 1.6 probe. So, in my opinion, 1.6 probe is more than enough to fragment even the hard stones. So, same telescope I use for the ureteric catheterization and also for the mini perk. So it's we don't need much instruments for mini PCNL, and I prefer to use pneumatic lithoclass. It's a locally made. And coming to the procedure, as I mentioned that we perform under spinal anesthesia, except in the children and in prone position. As I mentioned that my aim, most of the time, whenever possible, I go through the mid calyx. When we go through the mid calyx, it acts as a neutral position, and we can swing our scope up in the upper pole and down in the lower calyx. Not only that, it forms a shortest route to the kidney, and we can also inspect up to the upper part of the ureter. So usually, I hope you can appreciate this 12 trip and
Yeah.
12
Yes,
trip
yes.
tip.
Yes,
This
yes.
one is the 11, this one is the head end and the foot end. So this is a posterior axillary line and the iliac crest here. Usually when we go to the metacardiacs, it generally falls at this point. So it varies from patient to patient and the anatomy of the is individual. So
Do you use, sir, do you use bolsters? Or what is your
yes,
criteria?
yes, we do use bolsters in order to facilitate the ventilation of the patient as patient is under spinal anesthesia. As this patient is very lean and thin, I kept only small bolsters in the renal pelvis and one over the chest. So regarding this puncture and all, usually I prefer to go more lateral punctures like this, or even for the supra 11, I use more lateral punctures, which gives the high maneuverability, and we can swing the telescope up and down without much difficulty.
Sir, there is a question from the audience. How do
Please.
you place the bolster, whether it is vertical or horizontal?
It's a horizontal. We just placed a small bolster. We just roll a this
Gown.
drape. It's usually I prefer to keep
Horizontal.
horizontal. That's
You
true.
use two or simple a single one?
It's a two. You generally.
Okay.
It's a two. So is it clear regarding? So I'm talking about the punctures and all. And today, this afternoon, I'll be talking about the supracostal punctures. As I mentioned that mostly we go about 80% of the cases, we go to the middle calyx whenever possible. So even we make a puncture, supra 11 and more lateral puncture, but I see many people, they make a more middle puncture, which may cause a more torque and high chance of bleeding. So shall we start?
Yes, please.
Shall we have Siam view?
Yes. Siam, are you having it?
Not.
Kindly rotate the Siam, please. Someone. There's no person in Siam. Siam, rotate. Okay. Okay. So, are you having Siam view?
No, not proper.
Siam view is not proper.
Cameraman, please, can you focus it better?
Focus it better
Skype
and
is being focused.
picture-in-picture view is required. What he is doing and
So,
Siam,
can you
both.
rotate that one also?
Surface
just
view.
This is indoor view.
Okay, that's perfect.
Can you zoom in, please? Yeah, that's better.
Okay. So, are you having surface view and the fluoro view?
No, surface view is not there. So let's have surface view plus Siam, both.
So, I think we have only one camera, right?
No, there are two.
Okay, now in OT2.
Okay.
OT2 they might be one. Okay.
There are two cameras. One camera is focused in the TV monitor.
Siam should go directly from the monitor. Then only it will come. Otherwise, it will not be possible simultaneously. That is, there is a better one.
Maybe they are using that camera. You focus on the surface view.
Okay.
So, okay. So, how I minimize this X-ray, we just click one time and plan. This is a surface view, as you can see here. And okay, now we'll inject the contrast. We'll inject the contrast.
Can we have the Siam view again, please?
There seems to be only a single camera.
Oh,
Looks like.
yeah, but yeah, we need to
You
focus
pull
it
down a little bit.
once.
See, are you having
Yeah, we are able to see.
surface? No, not much. Okay. See, are you having Siam view?
Yes. Yes.
Inject some more contrast. So usually we choose the dilated calyx one. So I'm not having proper calyceal system here.
What is your opinion about this pelvic calyceal system, sir?
This seems to be a little challenging
Quite
one.
dilated, or is the
It may be the extrarenal pelvis.
The calyces are not seen well.
Yeah, that's
Calyx,
true. That's true. So probably I'll go through the lower calyx. It's most prominent, as you can see here. So how I advance? So my needle will be more horizontal. It's not vertical. I advance the needle about 4 to 5 centimeter, as you can see here, and do not advance beyond that. And you see the movement of the kidney with the needle, right? And at this point, I may feel giveaway. As you can see here, I'll advance it. Can you appreciate the movement of the kidney with the needle? Huh?
Yeah.
Yeah, yeah.
Okay. Probably it's a monoplanar. So the needle is more horizontal, as you can see here. See, I am in the system.
Yes.
See, why I want to make this track more horizontal. In mini PCNL technique, once the stone disintegration is done, we remove this fragmented stone by means of irrigation. That's why I want to achieve this track more horizontal.
Yes,
If I make a more vertical track, the irrigation is not enough to evacuate the stones. Either we must have an irrigation pump. Right?
True.
So, so
Got your point.
I prefer to use zebra guide wire. So I hope you are having this surface view.
Yeah, surface view is very clear.
Dr. Sanjay, Dr. Ashish here.
Hello, Dr. Ashish.
Yeah, good morning. Yeah, nice puncture.
Yeah.
You were discussing about trying to keep the puncture tract a little horizontal. So, does the calyx decide your direction of the track, or depending on what technique you are going to use, you would define the inclination of the needle while going in?
Yes. It depends upon the calyceal system. We cannot decide. We keep the patient in prone, we inject the contrast, only then we can decide which calyx to go. Because sometimes you see in the CT or IBP, it's totally different when you perform a on table, when you inject a contrast. I hope most of you will agree with me.
Yes.
Yes, yes.
So can I have a zebra guide wire, please? So this is the zebra guide wire of 0.035. As you can see here, this looks like a 0.25.
Any particular reason for zebra wire?
Yes,
I'm
I'm
not,
going to show
gliding.
you. I'm going to show you that. I was waiting for your question only. Usually, we dilate with these facial dilators. These are radio opaque. As you can see here, these are radio opaque dilators. So when we use Terumo or PTF, sometimes with the respiration, it buckles very easily.
Okay.
But if we use this zebra guide wire with the facial dilators, it glides very easily. It goes very smoothly. That is the reason.
Yeah.
Okay.
Dr.
Okay.
Sanjay, do you feel sometimes if you put the zebra wire through the initial puncture needle and then you want to adjust it, you want to withdraw it, sometimes it gets peeled or something and then it
No.
doesn't come out?
Very nice question. So once you insert your guide wire, you cannot and you never pull this guide wire. Otherwise, these guide wires are very expensive as compared to PTF or the Terumo guide wire, right? So once you insert inside, if it is not in a place, we never pull out. We have to pull along with the needle and you make another puncture.
Okay.
So can you just inject some water, please, so that the system is distended and I can easily pass this. Okay, are you having this surface view?
Yes. Yes.
Okay, let me check. Okay, there's no free flow. Okay, let's see. See, it's a mobile stone. Show this fluoro view, X-ray. Are you having fluoro view?
Yeah.
No,
Okay,
sir.
see, I'll move my guide wire. You can see this stone is floating.
Fluoro.
My guide wire is within the
The
system.
fluoro is not clear, sir.
No, please hold this. I'll just give a small nick incision about 5 millimeter. Okay, that's it. So, okay, you don't use this. Okay. So always I prefer to use the smaller one, 10 or 12. Only then I advance with the 18 or 20 French. This makes much more easier for the subsequent dilatation. See, usually I dilate just up to the calyx. I do not advance much, as you can see here. At the same time, you ask the assistant to give a saline push from below, and you can confirm it.
Yes.
Yes.
Okay. So this is my first dilatation, and maybe I'll go with this is the 20 French with the straw. Actually, I do up to 18 French in most of the cases, but just for the demonstration purpose, I'm making in up to 20 French, just to demonstrate you this 20 French sheet, straw. See how I dilate this system, I just gently rotate, no force. See? Okay. It's a very gentle dilatation, no need of force. This sheet is radiolucent, we won't be able to see. Okay. Yes. No problem. No problem. No problem. Okay. So we are shifting to another theater as Chandramohan is waiting for.
Okay.
Yeah. Okay.
Right.
Okay. Camera, just a moment.
OT1 पहले OT1
We'll just check inside.
और OT2 बंद करना.
You have to hold over here. Pani? Water, please.
Give us OT1, no?
It's too high pressure.
Mic on,
Ah,
please.
Yes, we are with you, Dr.
Yes, sir.
Chandramohan.
Sir, we have finished the case, and we have done 110 predominantly fragmentation mode with 500 micron fiber. During the surgery, 600 micron fiber caused little bit of vision disturbance. These are the small burns which I have produced while doing lithotripsy. This is the disadvantage of the laser. Sometimes burn will happen. This is a proper calyx. And to see, because I have punctured posterior calyx medial, this looks like infundibulum, but is not. This is the center of the calyx. Usually, you see anteriorly, then you will go. There is a clot here. In that clot, I am going anteriorly. You should be careful while going here into the pelvis. Now, this is a pelvis, and this is the ureteric catheter. This is the ureteric catheter.
Yes, yes.
So anteriorly, I am coming out. I will show that. This is a compact system. So one calyx to other calyx movement is very difficult. So this is a clot. This is a lumen. This is a lumen. I am coming back to the calyx like this.
Yes.
Quite anterior. So if you don't detect this, it is difficult to pass this. That's why sometimes better to keep the guide wire. So this is the pelviureteric junction.
Yes.
So the advantage in supine is ureter from middle calyx easily you can go like in prone. So I am putting directly with the scope, the stent. No
Will you be
sir.
putting in DJ stent?
Yes, sir. DJ stent. I will not put nephrostomy tube. Give me one, sir, sister. That's all. Should I inject contrast and show once here? So that you can take the camera off. I can put the stent later on. No problem. Give me the contrast. Or put the contrast from below.
Yes.
So that finishes the what happened to anatomy where we are, we can understand. Then you can go to the other theater. Inject. Thick contrast you can inject now. Inject, I will come out slowly. Siam. Are you showing the Siam now? Siam, please. Screen. Can you show Siam? Can you see now, sir?
Yes.
I am crossing the inject contrast. Siam. See, I am coming out. Inject contrast. So if I come out, that will fill now. Inject contrast. Inject. See, that is filling now.
Yes.
My calyx is filling.
Yes.
My calyx is filling. So I will stay back here and do the stenting. That's the end of the. Now contrast. Inject. Siam. See, I am coming back. This is the calyx which I have entered. Medial.
Yes.
posterior.
Yes.
This is the calyx. Inject now. One time I will inject and see that is the calyx which was there with the stone. Right on the pelvis. No extravasation, no intravasation.
Yes.
Thank you, sir.
Right. Thank you so
Very
much.
nice, beautiful demonstration.
Thank you.
Thank you.
The
Thank you.
audience is clapping for you.
Yeah, no problem, sir. Thank you.
Can you shift on to OT number 2, please?
ये जाएगा नहीं सर जाएगा.
Okay. Can you shift to OT number 2, please? Yeah, we are on OT number 2.
नीचे से guide
Okay. Dr. Khadki, we are with you again.
Hello.
Yeah.
Yeah, we are
Okay.
with you now.
So I inspect the system with the telescope, and sheet is inside the pelvic calyceal system, and we just remove the guide wire. We were just waiting for you. That's fine. So Pani, please. Pani, please. Pani. Okay. So are you having this endo view?
No,
Not yet.
That's
not
the,
yet. And
Can someone show the endo view?
Yeah.
yeah, now it is there.
Okay. See, that's the stone and ureteric catheter. Yeah, that's the PUJ below here. See, that's the edemators. So I place the sheet close to the stone. Now what I do is, this sheet is long, so I will cut this sheet. Where is the scissor? So are you having this surface view?
Surface view is there.
So
Yeah.
I make it short.
Yes, yes.
So once these stones are fragmented, we remove these stones by means of irrigation only. We do not use forceps. So
Do we need to clean the scope? I think it is
No,
slightly blurred.
Yeah, it's not a good one. I think
Okay.
they don't have another one. Do you have
Won't you
another
prefer,
telescope?
won't you prefer the laser for this?
No, I prefer to use pneumatic lithoclass. Pneumatic lithoclass is very cheap, very efficient,
And locally made.
and we
Yeah.
cleaned several times this camera, but
There is a suggestion, sir,
Yes.
from the audience. They're saying that there may be a fogging between the lens and the camera.
we cleaned several times.
Okay.
But this
So it's a
camera
prob-
seems it's damaged.
Oh,
Okay.
right. Thank you.
Maybe we can change another telescope. Kamlesh, can you get the another telescope if you have? Just we'll wait for 1 minute.
Dr.
So
Sanjay,
regarding the energy source, as I mentioned in my earlier, that I want to make this technique as simple as possible.
They have done
You-
everything. They have done
Use the facial dilators, yeah, and use the energy sources, not the laser and all, but I prefer to use pneumatic, which is more efficient, I find, and I have an experience of almost 12,000 mini perk experience. I have used all the energy sources, but I find this pneumatic lithoclass is the best for stone disintegration. Only in certain cases, I prefer to use laser.
Laser.
That is, when we have a very hard stone with the thin renal parenchyma, in such situation, when we use the pneumatic lithoclass, there is a high chance of perforation. In such case, I prefer to use laser.
Laser.
Otherwise, I go with the pneumatic lithoclast.
Dr. Sanjay, I
yes.
have a question. If
Yes, please.
yeah, so this straw thing as a sheath is a very good idea. The only how would you like to comment about the maneuverability of the straw? So does it tend to kink? Number one.
Yeah.
And number two, if the case has to go on for a longer time, how long does it last?
No, see, I'll tell you, very good question.
And how
It's
do you
a
stabilize it?
renal pelvis stone. It's a straightforward. Only in such case, I prefer to use this straw. Otherwise, if there is a lower calyceal stone, I have to come from middle calyx to lower, then I do not, I use this more stiffer one.
Okay.
It's a non-collapsible. If you see this one is a collapsible.
Yes.
Yes.
Can you see
Yeah.
that?
Yeah.
So in angulated system, I do not prefer to use this straw, only when there is a renal pelvis stone.
Okay.
Right? So we have another camera.
You
Okay.
autoclave it, these straws?
Sorry?
Do you autoclave the straw or
Autoclave
do you
No.
by
We keep in Sidex for a
side
few
X?
minutes.
Okay.
Okay.
Keep it in a bottle of Pepsi. That's
So this
acidic
is the
emulsion.
irrigation. This is the irrigation flow. I have a irrigation
Keep it
pump
in
which
coke
is
only.
made in China. So here we are using 3-liter bottles. Okay. So can you appreciate the irrigation flow here?
Yes.
Yes.
Okay. And just focus kar dena, end of view. So there is a
That's
stone.
better.
Yeah. This
Okay.
camera
This is much better. So
telescope
I
is
will
better.
advance the sheet closer to the stone. Okay.
Yes.
Now I start fragment. What I do is I don't want dusting. I need fragmentation of 3 to 4 mm of size, which easily accommodates in our sheet, so that stone evacuation is much more faster. As you can see here, I am using 1.2 mm probe, just 1.2. See? See, just fragmenting it in pieces, but it seems very hard stone. See?
Yes.
Looks like monohydrate.
True.
See, very hard.
Dr. Sanjay,
Right.
what is the advantage of the straw over the normal rigid plastic sheath?
It's a very cheap.
Cheap.
So anyone can start with the minimum instrument if anyone planning to start mini perc or conventional PCNL.
Yeah.
So
Dr. Khadgi,
yes.
since you have already started that procedure, now we'll shift to back to our own auditorium and we'll have another lecture. And by the time you'll complete, just let me
one
know.
minute. I just want to show you for
Yeah,
1
sure.
minute just how to remove these fragmented stones.
Okay, right.
Yeah,
See?
okay.
Almost
wait for
we are done. Just 1 minute.
Okay,
Yeah,
no,
sure.
no problem, sir.
Okay.
Ashish,
Just
you have
1
to
minute.
wait for 1 minute.
Meanwhile, sir, one question from Sanjay, sir.
Yeah.
Sir, it is said that the lateral vibration of the pneumatic lithoclast can damage the scope. What is your experience, sir?
Yes. If you keep this energy source more than 5 bar in your machine, and another thing is when you bend your scope, when you come from middle calyx to lower calyx, when your scope is slightly bent, at that moment, when you hit with the pneumatic, there is a high chance of breaking the telescope. So what I did, I advanced the sheet. Can you appreciate the stone
Yes,
is coming,
yes,
following
yes.
me? Now, again, I advance the telescope. Will make the close to the stone, see? Okay.
Yes, it's beautifully
Yes,
seen.
Okay.
Nicely
So
seen.
I'm not using any forceps.
Yes.
See, all stone. It's almost done. See,
Yes, yes.
only 1 or 2 pieces left.
So, in spite of the collapsibility of the that straw, the evacuation of stone is as good as the emplas.
Yes.
Right.
It was very nice.
See,
Excellent demonstration.
see. We are
Yeah.
not using forceps.
Sorry.
Okay, almost done. And these are the stones. Can you show?
Are you irrigating through ureteric catheter? You are pushing some saline from below?
No. At the moment, we are not pushing, but it's better if you push
Yeah.
at the time when I take out my telescope from the working sheet.
Yeah.
True.
So that, okay.
Yes.
So can you see these
Yes,
stones?
yes.
Yes,
Okay.
very much.
It's done. Almost small stone is left. So my practice is tubeless. We do
But
not
you would
keep,
put a stent?
we keep a double J stent.
Double J stent.
No.
Yeah.
Fragment.
Okay.
Okay. Thank you so much.
Thank you so much.
Very
sir.
nice.
Yeah.
Excellent demonstration.
Little class. Thank
You
you
can
so
hear
much.
from the clap,
yes,
sir.
Yes. Thank you so much.
Right.
It's 2020 French.
Yes, Ashish.
Actually.
Good morning, everybody. I would like to, at the outset, thank Chhattisgarh Urology Society, the West Zone, to have invited me for this talk. The technique I'm going to talk about basically is the 5-pang perk system, which is more well known amongst the young urologists, the urologists who are just starting off PCNL, and there are quite a few young urologists who are using the system at the moment. Today, most of the seniors know that I always talk about 5-pang when it comes to PCNL because it removes most of the drawbacks of the conventional PCNL tract dilatation and sheath placement both. So I'm happy to declare today that it's already patent granted. And basically it consists of a sequence of tubes which range from the initial puncture needle, which is the first 3 parts, and these form 18 gauge, which are used for puncture, and this is followed by the serial tract dilators, which are 3 in number. So this is the initial puncture. These are the 3 tract dilators, after which follows a locking rod, and then we have the various dilators. All are made up of metal, and so it basically converts the flexible tract dilatation system into a rigid one. And these are the dilator sets. So today I'll just go through a brief slide demonstration with a semi-live sort of a demonstration. The live videos are going to show right PCNL being operated, and the perspective or the camera has been placed on the opposite side near the head end. So how do we go off with a 5-pang PCNL? Well, we first do an initial puncture with the help of a 3-part needle. The stellate is removed as we usually do it. So this is how it looks. I usually use the bullseye technique. We remove the stellate. Then one can use a 2 cc syringe to aspirate and confirm whether we are in the system, and remove the inner part along with the syringe once the puncture is confirmed, so that you are left with a 18 gauge tube in the kidney. This is how it will look. So a 2 cc or a 5 cc to aspirate. So you have a clear liquid there or urine there, and then you remove that hubbed part along with the syringe. So now out of the 3 parts, only the outer part, which is 18 gauge, is left inside the system. Now we are going to look for free flow of fluid, which usually we do. We never aspirate. So a free fluid can be easily seen if you push saline through the open-ended catheter. Then you put in a glide wire through this 18 gauge. So basically, once the initial puncture needle, we have a successful puncture. We never remove the initial puncture completely. Through the initial puncture needle, the 18 gauge will remain there till later part in the procedure. So you insert the glide wire. Once the glide wire is inserted, then you put in a 9 French part over this part 3. So you have to just telescope the 9 French over this initial puncture needle. You only hold the outer part and push it in. It never overshoots. Then comes a 12 French over this 9 French. Each part is subsequently shorter in length, so that you always know from outside how deep you have gone. So you have to just push the 12 French over the 9 French. And similarly, we will do it for a 15 French. So this is part 5 of the system. This also will have, there are 2 options in this. One will have a groove, a slit in the center for those who like to have a safety wire during PCNL. So this is a slit part 5 that I'm demonstrating here. So this is the part 5 which we are just going to push. This is the slit. So this is slitted throughout its part, throughout its length. Once the 5th part is inside, we are going to remove the inner 3 parts now. So now we started with the initial puncture needle, a successful puncture.
and without allowing the needle to be bare at any point of time, we have continuously covered it with a stainless steel piece. We have dilated till up till 15 French. Now this wire can be pushed, exteriorized. These are the three parts coming out. So now you are left with a wire inside part 5. Now for those who want a safety wire, you can exteriorize the wire. This wire can come out. You are left with a 5th part. You can put in a second wire through this. So the wire just comes out like this to the side of the sheath. Then you would put in the rod, which will go and lock in this part 5. So this is how the rod is put. You can either put in the wire through the rod or before the rod or through part 4 also, whatever is your choice. Then comes the dilator set, and it will directly go over this and lock. So this would be the part 7, which is 21 French, 18 French. And then subsequent dilatation to whatever size you want. So if you must have seen, there are no Teflon dilators, so there's no struggling with whether we are going into the same track. Once your needle is in the pelvic calyceal system, all your dilators will go over that initial puncture needle itself. And then you place the sheath, whatever kind you want to. It may be a mini puck sheath, it may be a conventional ampullage or whatever. So sheath placement is just like you usually place it over any rigid dilatation system. Your safety wire is outside and your working wire is inside. You have a choice of the wire, whatever wire you want to use, but usually I prefer the glide wire or the Termo wire. And then the inner dilator set will come out, leaving the sheath in place. So that's how you just pull out the rod, keeping the wire in situ. And then you'll have the ampullage sheath here, along with one wire which is inside the sheath and one wire which is outside the sheath. Now you have the choice of keeping either wires or removing both wires. So basically, whenever I go for the live workshops and see people operating, I'm very happy to say that we never have these problems of the conventional PCNL puncture at our center. Because once you have a good, successful puncture, you will never miss the track because you are never leaving the wire bare. There's no chance of the wire getting kinked, slipping outside the kidney. Usually in previously operated kidneys, it's very difficult to push your dilators through the fibrotic retroperitoneum. That never happens because you are constantly working with a super rigid system. So it prevents extrarenal wire kinking and slippage. If the patient is under spinal or you are using inspiration expiration under GA during puncture, then usually you might get a S-shaped tract. And after you remove the needle, the glide wire takes a sort of S shape. That never happens in this because you never leave the glide wire naked or bare. There's a constant tract tamponade because we never reduce the size of the dilator. We are sequentially increasing it without ever releasing the tamponade. So there's no extra renal extravasation, and it also sort of acts as a bleeding tamponade. Also, I've seen that there is less pain in the post-op period because there is less extravasation while we are operating also. In previously operated kidneys, it is easy, and both it can be used with fluoroscopy as well as ultrasound, and it reduces procedure and radiation time. So this dilatation, if you do it fast, it hardly takes more than 3 to 5 minutes after a successful puncture. And definitely saves the disposable and wires. And it is compatible with all the sheets that are available in the market today. Thank you so much, sir. Questions are most welcome.
Thank you. Excellent. Very nice.
Excellent.
Sir, have you used this system for supine PCNL?
I have not used it for supine PCNL because there is a little conceptual problem with me. I still am to find an indication where I could not do a prone PCNL and have to shift to supine PCNL. But I think only the puncturing technique is different. Otherwise, the dilatation is going to be same.
And on the contrary, this might be more beneficial in supine PCNL because rigid or semi-rigid dilatation is more difficult in supine PCNL rather than prone PCNL is what I have observed. So this might be more advantageous.
Ashish, you have kept it here?
No, I have not kept it here. The first 5 parts of the needle, I think, is around 20,000 or something. So till the rod and through the part 5, any other rod also goes, like the normal rods that we get in the market or any standard, because it's already 15 French, and from inside it is 14 French.
So your first 5 parts are 20,000.
Around.
Around.
Yes.
Okay, thank you very much, Dr. Ashish,
Thank you
for
so
an
much.
excellent demonstration.
Thank you so much once again for the opportunity and the hospitality. Thank you so much.
When we listen the name of Dr. Ashish, sir, the first thing which comes to our mind is innovation. He is one of the best innovative urologists in India. We are very, very pleased to have him on the dais, and there is a memento for him. Thank you. Thank you. Thank you.
Dr. Kanaskar, are you able to hear me? OT से connect कर दें.
Photo करते हैं.
Okay. Thank you.
Can you connect to OT?
कर रहे हैं.
Anybody in the OT, please? Are we audible?
अभी कुछ नहीं. Okay.
नाही, somebody मुळावकर किंवा कोणाला फोन करायला.
मी जयंतला फोन करतो.
Just contact OTs, na? What is happening? मतलब any OT is ready.
Hello. Hello. Can you hear me, sir?
Yes, yes.
Yeah, we have just
Yeah.
finished both the cases.
Yeah.
We are extubating and shifting patient outside, so we'll have need 10 minutes time.
Okay,
But
so
in the meanwhile, can you give us some history of
the next patient
case and who is going to do it?
So
And-
next case is one PCNL, Dr. Sabnis is going to do it. And the other case is RIRS by Dr. Nanjappa.
Okay, so can you tell us about the patient, and we can have a chat with Dr. Sabnis? What is his plan?
Yeah.
So we are
I am
already
giving it to Nanjappa, sir.
okay.
Okay,
Fine.
Nanjappa, you
That's
give it.
also fine.
Hello.
Yeah.
Hi, Nanjappa.
Hi, sir. Yeah. So the next case is a 35-year-old. I'll tell you about the RIRS case. It's 35-year-old male patient with a 1.1 centimeter pelvic cal, and he has a lower calyx also 3 mm fragment.
Okay.
So let's see, but there is no contrast study still done. It's just a plain CT and an X-ray KUB. Patient
But,
has
patient
been,
is stented already.
yeah, but the stenting is just done around 6 days back, I think. 6 days back. So the stenting is,
So
we've
how
already
many
put a
days do you
stent in.
expect? Normally, pre-stenting.
Normally, pre-stenting, we wait for some more time. I mean, this is quite early because if you have to go in the second time, you have to be successful. So at least we follow 14 days. At
But
least you
generally
should
the
wait for 10 to 14 days.
Guidelines are what? 10 to 14 days?
See, the guidelines are normally over a week. Now, I'll tell you the reason. There is something here because in 10 days, what happens is there's a biofilm which starts forming on your stent.
Okay.
So till that 10 days, after 10 days, when you start doing these cases, then you can have a chance of infection because of the biofilm already being formed. So it's always better that you go on just at the 10th day or just before 10. But in Indian ureters now, better to wait till you are really going to go in, because these all data come from where they don't require a stent actually, because the ureters are already quite capacious.
Okay.
So better wait for 14 days, because here when you want to go the second time, you have to be successful.
That's a good piece of information.
Yeah,
Manjappa.
so it's always better that wait for 14 days and then go in for the procedure.
Okay, okay.
So here we are planning to use the Quanta laser. So I'll be planning on this side with the holmium laser. We are planning on using the holmium laser here, and it's a 30-watt holmium laser from
Yeah.
Quanta. And the scopes, we have the endoscope from Biorad,
Okay.
which is the endoscope sleek, and then we have the Olympus also, the P7. So we are starting with the endoscope, and then let's see how we go about doing it.
Can you give your opinion about a comparative, your personal opinion about the comparison between the different scopes?
See, just as I was mentioning when I was talking to you all over there,
Yeah.
that we normally nowadays we try to prefer to go for a digital scope, because the vision is quite good, and things are changed over a period of time. Initially, if you would go and see that you had these scopes which were quite thick, I mean diameter wise. So nowadays the sleek scopes are available. So if you go to see, though Biorad says that its scope is 7.5 French, it's only 7.5 French at the tip. So you don't try to put it through a 9.5 French axis sheath. It will go through a 10-12 axis sheath. So that's how, definitely now can we say that has fiber optic scopes really gone off? No, still fiber optic scopes are useful, because in Indian ureters are quite narrow. Remember that. So
Manjappa, which sheath is available? 10.7?
now here we have the 10-12 axis sheath which is there from Biorad only. And I hope we have the 9.5, 11.5 axis sheath, but I'm not sure whether Kamlesh has made that available.
What about the sterilization? How do you routinely do it, and
See,
what do you recommend?
normally now all these scopes which we are using are reusable scopes. So you have to, use the scope again. So as you said, reprocessing is a very, very important step. It's very, very important. So here the most important thing is how do you reprocess your scope. So if we try to follow the ideal process of reprocessing, like using a STERAD, which is the ideal way of reprocessing, definitely it is good, but it becomes very, very expensive.
What did you say?
So
What-
a STERAD, hydrogen peroxide re-sterilization. So that becomes quite expensive to have a STERAD with you. But then high level disinfection is what is being followed at most of the setups. And
Parasif?
so yeah, you have a mixed bag of both Parasef with Sidex. So Parasef is always better, because Parasef it can be used just for 24 hours and it can be discarded.
Yeah.
And it can be reconstituted. So it's always better to use Parasef for re-sterilization. So the problem here now comes in, the new generation of scopes have lot of ifs and buts, that only this part of the scope should be dipped, that
Yeah.
spot should not be
Yeah.
dipped, this should not
Especially
be done.
UMD
So I
scope.
think these are the things, we have to be very careful. Whenever you want to re-sterilize or reprocess your scope, the whole scope should be dipped into whatever high-level disinfection you're using. So that's very, very important. So, and the time which you take it, and you see that you properly, because in RIRS, the most important thing over there is sepsis. So that's why this one important thing we always have to see or take care is how you reprocess it. So even all your disposables and all that. So if you have a mixed bag of two things, like if you have a ETO sterilization with you along with high level disinfection, everything is taken care. Like you can ETO, most of our disposables, though the axis sheath baskets, we cannot use it in one time. It's not a one-time use because it becomes quite expensive. So in these cases, you may reprocess it, or so that time if you have a mixed bag of ETO along with a high level disinfection, this becomes a better thing to go about
have you
reprocessing
used
everything.
UMD scopes? And if you have
No,
used,
I
what do you
don't have
do?
an experience of a UMD scope, but I believe their vision is also quite good. So, but I don't have an experience of using a
Kandar,
UMD scope.
you want to say something?
Kandar.
Can we have, sterile sheath over it and then do it, UMD scope?
The fact
No,
that
like,
UMD scope cannot be dipped completely to the side X, the head end cannot go inside, unlike the biorad which can be completely submerged in the side X.
You are
So
aware
that
of
is,
it.
you are aware of that. So what he's suggesting is, right, Mike, please. Hello? Yeah.
Actually,
Like, camera cover, but can use it over the Nanjappa. I was thinking that why not use the camera cover over UMD scope right up to the end and then use it?
how
I
come?
think, see, Indians are known for a lot of
No,
jugaad.
no, no.
So, you can talk this as a jugaad and you can do a trial and see whether you get successful on this. But
Maneuverability
actually,
will
I
be
don't think it would be recommended.
Yeah.
So if it is not recommended, you have to see recently there has been a lot of scopes being recalled by a company because they have taken out high level disinfection also from their list of reprocessing. So it's a very major company all over the world has just a month back recalled all its scopes back saying that our scope had high level disinfection, but now high level disinfection cannot be used as a standard way of sterilization. So they have recalled it back and only either using a sterad or ETO, this would be recommended in certain scopes. But I think most of us will vouch for high level disinfection with a ETO sterilization. See, doing a ETO for your scopes, it's also ideal because you already have a ETO with you. Why don't you use it for your scope? But I've seen that using an ETO sometimes damages your scope, so that becomes a problem. And Prashant, you can join me. And so, it is so that it can damage your scope. And that's why, deflection of the scope, the outer sheath which is there, the outer covering of the scope becomes a bit hard after ETO. So we try and avoid ETO sterilization, so that's why we always try to use a sterad. And, so how do you reprocess your scopes,
Nanjappa,
Prashant?
this Kandarp is waiting to make comment.
Oh, yeah, please, Kandar.
Okay, so I have used the UMD scopes, so that is a DPRA scope, which is a reusable or limited use ureteroscope. I have no experience of dipping it into the Sidex or Paracep because in my hospital, we strictly do it with the sterile sterilization. So plasma sterilization. Plasma sterilization. Plasma sterilization is very expensive. So if you have a plasma sterilizer available in your hospital, I bought it because RIRS is my bread and butter for me. So that is the reason I am doing it. Because the infection problem is the biggest problem with the RIRS. Because you don't sterilize properly, you will lead to the
What is the cost of
now sterile sterilizer? I think the sterilizer itself is going to cost almost close to 25 lakh rupees. It's the cost of a sterilization, and every cycle.
Probably the new one is costing 35.
So I don't know. I bought it almost.
Because in your conference AIE, I inquired about it was around the newer model.
I have no idea about it because I bought it almost 5 years back. Now many companies have come out with the sterile sterilizer. Indian company also have come out with the sterile sterilizer. I don't know how effective it is, but there are about 3 companies now dealing with the sterile sterilizer. Johnson and Johnson. Now the company's name is changed ASP or something like that. Second is one Indian company and one Korean company. These are the 3 companies dealing in India. Now, the biggest problem of RIRS is infection, as I said. Now, we are using a limited use, the newly introduced disposable scope, where one scope can last for 10 cases or maybe 20 cases, or some people are using for 50 cases also. So, in that case, if you invest into a proper sterilizer method, if you can't afford sterile, fine, no problem. Then at least invest into the ETO sterilization. ETO is a good method. Now, ETO and sterile both will decrease the life of the scope, which is also I have experience in my practice because most of the people say that my scope, supposing when I was using FlexX-C or FlexX-2S, the reusable scope, one digital and fiber optic, that time some people say that my scope lasts for 200 cases. None of my scope has lasted for 200 cases. Almost 50, somewhere between 50.
Kandar,
Yeah.
Kandarp, you just mentioned ETO increases the life of the scope.
I never said
Decrease,
so.
No, decreases.
I
Oh,
decreases.
sorry. I think
I hope that's
that's why
anything.
I was like, I mean, first time I was in
I hope
this
that it
discussion.
can do that. I hope that it can do that. So, sorry, it broke my continuity. In fact, sorry for that. So, when you use this kind of a disposable, non-disposable, reusable scope, by using these two, certainly life is going to be between 50 to 70, 80 cases in a reusable scope like FlexX2S or FlexX-C. My scope has not, they have not lasted for more than 100 cases. So now what I do is that I use a steroid sterilization for the DPRA scope or a BioRad scope. Well, both the scopes are excellent vision with both the scopes. So you can make your own choice. Now the scopes are available for 60, 70,000 or 80,000 rupees. I don't know the exact cost.
Yeah,
But if you
around.
buy it in a bulk, you will get. And almost every scope, they last for between 10 to 20 cases. Some people use it for more. In my practice, I have seen that they last for 10 to 15 cases because I take even a larger stones also. But then the per patient cost will come out to 5,000 rupees or 7,000 rupees.
Yeah.
So, and you are using a base sterilization method. If not sterile plasma, use ETO. ETO costs 2 lakh rupees or 5 lakh rupees. And the per cycle cost is nothing. So that is the reason, and you can have many scopes because you are buying 3-4 scopes. So if you have got 3-4 cases lined up, there is no problem because ETO takes about 12 hours for the complete sterilization process, while plasma takes about 35 minutes.
Correct.
So in my hospital, I use plasma, but you can certainly use a ETO sterilizer, and then it is a balance that you are preventing infection, buying a cheaper scope, less possibility of a damage to the scope. That is also very, very important. And even if you break the scope, you are not making a big loss. So you can use do RIRS in your regular practice.
Very well
Prashant,
summarized.
you were to make some comment from the OT. Prashant?
Prashant Malaukar.
Hello, one question, and can I have that question? See, the difference between high level disinfection and sterilization is only that it does not kill the spores.
Yes.
Do we encounter infection by spores in urological practice?
Dr. Kandar, there is a question for you.
The only difference between high level disinfection and sterilization is inability to kill the spores. Do we encounter spore bearing infection in urological practice? And hydrogen peroxide, parasafe disinfection, and both are using the hydrogen peroxide only. One is in the gas form, one is in liquid form. How will it make a difference in our clinical day-to-day practice, not the theoretical or legal aspects of it?
Whatever point I'm raising only the practical points. I don't understand the theory much in details because I don't understand about the exact dynamics of the parasafe or Sidex or hydrogen peroxide. I don't want to go into that much of detail. The important thing is that what is the result outcome? Because infection was a problem, is a problem, and will be a problem if you don't sterilize the scope properly, whatever method you use. So I have seen in my experience, I can share only my experience. So initially I also used to use a parasafe or not parasafe, that time Sidex was available when I started. And I was really scared. After the operation, all the time I was scared that this patient should not develop some kind of infection. Of course, there are many reasons for infection. It's not only the sterilization, your method of doing it, selection of
Yeah,
patients,
even the scopes.
Even the
everything, because there are many things and the,
The
pressure,
pressure
most
used.
important, your method of doing it. That's
Yeah,
what I'm
pressure
saying.
used.
So there are many reasons, but this is one of the most common reason. Now here you can see that they are using a camera cover. When you are doing, supposing the PCNL was done, and then we are worried that the water will probably, because of the water, there is a fogging or something like that. Now, in my practice, all the instruments, whether it's a TURP, PCNL or whatever, cystoscopy or whatever, we do a sterile sterilization. We never apply camera cover. You must have seen during AIE also,
Yeah.
that we sterilize each and every scope. For the workshop also with the sterile sterilization. We got a sterile sterilizer there at the hospital, and we sterilized all the equipment, all the company equipments were sterilized with this. And I'm happy to say that most of the patients, except barring one patient where there was a problem of bit infection, all the patients had no problem.
No, in
So-
fact, I want to ask you about infections following, like port infection for PCN, because that is more headache and it comes up late. At least in RIRS, you come to know in 1 or 2 days, 24 hours, 48 hours, the picture is clear whether there is infection. But in this one, PCN, I mean, they turn up, after 3 weeks or 4 weeks also.
See,
And that port infection is one of the biggest headache.
see,
A typical
let us all
mycobacteria.
of you answer that question. Okay, how frequently you have seen an urinary infection because of spore-bearing organisms? One, uh, just ask yourself. Don't need to tell us. Second thing, that the difference between the gas sterilization by either ETO or steroid is that it can go through any small lumens. Water, if you immerse the scope into the water, the lumen, the water or the liquid will not enter into the lumen unless you push it positively so that all the air and everything comes out. So whenever those who are using high level disinfection, my earnest request is when you immerse in it, you push all the elements with disinfectant solutions, whatever you are using, Parasafe or a steroid or lysoformin, whatever. If you do it well, that means the internal surface is also disinfected. The biggest problem is we just put it and forget it. That should not happen.
That's a good point. Yeah.
My question.
I think that's a you have to inject.
No, that
This
is
is what
expected,
I
actually.
was doing actually when I was using Parasep or.
It is expected
So
that you do
we
it.
used to push 30 ml of disinfectant into the accessory channel
Hmm.
before doing the procedure, so that
Yeah.
you can besides putting the scope in the side X, because you have to, as you say, that you have to clean the accessory channel also. That is, I think, normal practice. And then when you really want to use it, again wash it with the 30 ml of the normal saline.
Yeah.
So completely clean that, but that's a
Many-
standard
many
practice.
Many people
Yeah.
use betadine also like a holy water. Just put it and then use the
See,
guide wire.
our problem is that I can share my experience very clearly that I had a good infection rate when I started RIRS using this Parasep. Maybe I was not knowing the proper technique, let me put it that way. But important thing is that my sterilization, my infection rate has gone down drastically. Now I'm not worried. Yesterday, before coming here, I did 3 RIRS. I have not even called my hospital that whether the patients are fine or not. I'm sure the patients are discharged today. So, infection rate, your proper technique, proper selection of the case, and the negative urine culture. These are the most important aspect of in preventing infection. And these reusable scopes now, the limited use ureteroscopes, they will certainly decrease the cost of the procedure. That's why I think if you invest into a better sterilization method, whatever you feel like, I think that is good. I think it's a balance between the cost and the result. Most important, yeah. Yeah, please.
So I think all of us are talking about sterilization of the instruments. Most important is after you finish the case, it is your responsibility to clean the instrument properly, get rid of the fluid and dirty material, clean it once with Savlon, clean it then with water, and then air clean it, and then only when the
Dry
second
it
time
well.
you want to sterilize, that time
Especially
you're going
dry
to
it.
use the fluid. So these are important things.
That is Jackie very correct. But frankly speaking, I finished the case and I just walk out of the operation theater. Frankly speaking, not I don't want to be arrogant about it, but the point is that you have to have a dedicated staff if you want to do
Yeah, true.
RIRS on a very regular base. I have got 3 people who are really good into the assisting or as well as the post-operative
Anyway, the
proper
take-home
cleaning.
message is, channels have to be cleaned very well.
Everything,
They have to be dried.
either you do it yourself, and then when I bought
But it is to be
Flexex
done
C,
properly.
that time because it was costing very, I mean, 15 lakh rupees or something like that. Initially, I used to also, clean it myself, and this was recommended also, and this is still recommended. But now because the scope cost has gone down, the staff is trained, they exactly, probably
Yeah,
they
yeah.
do better job than what I do actually, because I will not put that many efforts. They are really putting a lot of efforts. True.
What about the OTA? Anything is ready over there? Nanjappa?
Yeah.
Yeah.
How far you are?
Hello, can you hear?
Yeah. Are you ready?
Are you ready? Prashant wanted to make some comment on something.
Prashant is not here now. He's gone out of the OT. He listened to your lovely discussion over there
Yeah.
with Kandar actually mentioning about, how important it is to reprocess your scope.
Nanjappa, I had raised the question of, port infection, post PCNL. Hiren is there around you.
Hiren is also there.
Yeah.
Yes.
Hiren, give your comments.
Sir, I think it is important to use new disposable and like Kandap Parekh sir said that urine culture is very important. In PCNL, I am seeing that this kind of infection is repeatedly coming
10, 12 is
because
there.
of atypical mycobacteria.
But
So if
every
new-
patient you do pre-procedure
Naya
excessive
urine
चाहिए.
is
culture.
used, if new guide wire is used, I think that infection rate will drop.
Kandap, every RIRS, every PCNL people do culture, urine culture.
I
And
think I think it is the most important.
I am
Most
doing it,
important.
sir. I am doing
Even if
urine
urine
culture.
culture is negative, supposing today I don't know what case I'm going to do
but
right
if it is
now.
positive, the question would be if it is
Positive, then
positive.
you make it negative by giving proper antibiotic depending on the culture sensitivity report.
So you wait for few days.
Then I wait for few days. So I think because I'm referred many patients from this region also, and I have talked to the doctor that you please before you send the patient,
Uretroscope
please
किधर
get a
है?
urine culture
Uretroscope.
done. If the urine culture is negative, then you please send the patient here to my hospital.
Sir, I'm going to wash up.
The question is, supposing you treat the patient again with the antibiotic, still the urine culture is positive. What will you do? How long you are going to wait? So the same question I asked Dr. Oliver Trexler during AIE meeting. If you have heard him, again you give antibiotics and treat the patient with and try to make it negative. Supposing after second time also the urine culture is positive, what will you do? Then I think you have to go take a call and go in and finish it.
Yeah, that's what you had shown in your flow chart.
Yeah.
guess,
So you must have seen that flow
Yeah,
chart.
flow
also.
chart was there.
Yes, correct.
Yes, Kaushik sir.
See, when there is a stone and stent, it is likely that the bacteria are already there in the stones and it is very difficult to sterilize. But if you are given a culture specific antibiotic, the blood level of the bacteria, antibiotic is enough to prevent septicemia.
Yes,
You may not be able to kill all the bacteria residing inside the stone, but there is enough level. So it is very important that even if culture is positive, if you are given culture specific antibiotics, there are very fair chances that he will not end up with bacteremia and septicemia.
Sir, we are going to wash up. We have taken an RIRS for right kidney stone. Dr. Nanjappa will be performing and I am giving him a hand. So, sir will answer the questions on the mic.
Yeah, can you tell us about the patient and the stone?
that you told,
Yes,
no,
you have already told about
You
it.
want to see the X-ray here? It's
Yeah.
there
Yeah,
already
yeah.
here. I think they have a non-contrast CT done. Here we can see a pelvic cal.
Then focus it.
So
Focus.
that's the